telling us her own experience later on.
Thank you. Glad to be here.
Okay, guys, it's all yours. You take it from here.
So I have the pleasure to introduce Professor Nelson Osiku. He will be talking about path to become a neurosurgeon. He's the president of the World Federation of Neurosurgical Societies. He's also the professor and chair of neurosurgery at the University of North Carolina in the USA.
Thank you very much. Am I able to have authority to share a screen?
Sure, you can. You are the host, so you can. Yes.
Okay, let's see. Let's see if this will do it.
And I see Yoko Kato is here. Hi, Yoko.
Let's see if this will work. How's that? Do you see anything?
Perfect.
Okay, so, all right. Got it. So thank you for the kind invitation. I will try to address the topic, starting with where I am right now. In the Carolinas. I just moved about a year and a few months ago after a long sojourn at Emory University in Atlanta. And I'm currently serving as the president of the WFNS. So why did I get into neurosurgery first? So this little credit goes to a medical drama series that engaged me when I was a young boy. And I'm going to play you the opening credit because I think it's a very powerful opening credit.
Man, woman, earth, death, infinity.
So Ben Casey was a medical drama series in the 60s on ABC that featured this young neurosurgical intern called Ben Casey, played by Vince Edwards. And I watched so many of those and got inspired to not just become a physician, but go into neurosurgery itself. So what is it about a career in academic neurosurgery? This is an incredible opportunity to not only be part of a specialty, i.e. neurosurgery, but also to be a participant in research, in teaching the next generation, in providing high-level care within a tertiary referral system. Of course, on the minor side, it's not the way to make fame and fortune. You make fame, but certainly not fortune in this business. So if it's fortune you're looking after, then you need to be in a different business. And there are other competing responsibilities as well that take up the time and the bandwidth of the neurosurgeon. What are the essential ingredients for academic success? And what is it that makes the great leaders and the great performers? First of all, I think it's enthusiasm, a passion, if you will, a desire, an urge, a continued yearning to be the very best at what you do and to produce the very best product you can. Over time, you will develop an academic identity, which revolves around your area of expertise and your contributions that are related to that specific area of expertise as you evolve from a resident, a trainee, a registrar, house officer, to a senior registrar, to a consultant, or to a professor, and so forth. And that's a lifelong thing. It never stops. Continued productivity, whether it's on the clinical realm or in the research realm, and collaboration with colleagues in neurosurgery and colleagues outside of neurosurgery in related disciplines such as ENT, orthopedics, basic science, and so on and so forth. Advancing one's career really boils down to three major domains: scholarship, in other words, the production of the dissemination of new knowledge, whether it's new basic knowledge or new translational knowledge, is number one. Writing, whether it's grants or papers, all which fall into the rubric of scholarship. Second major domain in academic advancement is teaching, residents, medical students, fellows, fellow practitioners for that matter, and other specialties. And then service to the specialty, clinical service or administrative service, both qualify. And these are the three main domains in which the path to academic distinction in neurosurgery goes along. I would urge that before you set out on a path, put together a 5-year plan, whether you're a medical student or a resident, trainee starting out, or even a junior faculty just appointed. A 5-year plan. That plan should include what your area of focus is, what is it that you're determined to obtain and succeed at, what are the short 1 year, 1.5 year, 2-year goals, what are the long-term goals, 4 or 5-year goals, what resources would you need to achieve this, whether it's time, money, equipment, support, and so on. Which things can you obtain by yourself? Which things do you need others to help you? And put this all together in a 5-year plan. And the mere discipline and focus of going through that thought process will help you on the way to achieving what that 5-year plan looks like. It's very, very, very important to get a mentor and find a mentor either at your medical school, your hospital, your university, even outside your university. You can have a mentor in a different country. You can have a mentor in a different continent. Find a mentor who's willing, able to support you so that you can bounce ideas off of that person, gain their support when you need to do things, whether it's writing a grant, writing a paper, applying for a job, looking for any other support, and communicate and meet with that mentor on a regular basis by phone, by email, by Zoom, and so on. I think learning how to collaborate and work with others is very, very important, whether they're colleagues, junior colleagues like medical students or residents or registrars, or more senior colleagues like professors, and their colleagues that should come from different areas, different specialties. So if you're a skull-based or tumor surgeon, you might have colleagues in ENT or oncology. If you're a vascular surgeon, you might have colleagues in neuroradiology and other specialties to collaborate with. Industry is also a fruitful source of collaboration, whether you're looking at new drugs and devices, to work with strategically in the development of these kinds of things is also a very good, ripe area for progress. And it's very important to focus. Many times you see people running in 4, 5, 6 different directions when they should focus on 2 or 3 things so that you're maximally efficient and you put your time to work with the best guarantee or the best likelihood of a return to investment, return of investment. So focusing along goes along with the development of an academic identity, who you are you a spine person, vascular person, oncological person? And those DNAs and those typesets differ from one to the other, and the path to success slightly differs from one to the other. As you define what it is that you want to become, you know which topics you want to master, which areas are those that are areas of your focus, and then apply that rigor in developing the knowledge base that you will put together in order to succeed. Spread that around, get feedback from colleagues and senior and junior colleagues, get critical feedback, and use that critical feedback to improve upon your plan and your path forward to neurosurgical mastery. And as you get help from others, you also must return that help and pay it forward and be generous with your own expertise. And as you develop your scholarship and your focus, put together and make sure that the work is coherent and it's becoming a body of work as opposed to these sporadic contributions. And you want to develop contributions that are important to your field, and that productivity is sustained and sustainable over the long haul, and that there's a clear, defined area of expertise that is beginning to accumulate as you make your path forward in your neurosurgical career. So with those comments, I will round up, and with the following, I wish you all, medical students, residents, registrars, house officers, good luck, work hard, play hard, maintain a good work-life balance, and put the patient first. And always remember that the work we do is a privilege and you should enjoy it. So with that, I thank you for letting me participate in your conference this morning. If you have any questions, I would be happy to take them now if you would like. Thank you very much.
Yeah, I think as Nelson has to go, we can take the questions right now.
There is one question on the chat. Maybe Sandeep, can you read that, please?
How can, it's by Go, how can neurosurgical residents balance the academic research and residency?
The question was, how can you participate in research during residency?
No, how can you balance the academic research and residency?
Okay. So the most programs that you would be in, if research is going to be a part of it, in order to balance the demands of clinical versus research, there must be some defined time that is set aside for the research. It's very difficult to pursue research in the midst of a very busy clinical service. So if you're going to be in a program or in a training environment that provides or has facilities for research, the first question you must ask is what time is allotted to that? Is it in your 5th year of training, your 4th year of training? Is it 12 months? Is it 6 months? There must be, first of all, a commitment of time. And that's, I would say, the number one thing. Second thing is the resources, because after time comes resource. Whether you're doing basic research or translational research or clinical research, whether you need a research coordinator or you need equipment or supplies, there's got to be some financial resources tied to the time allocation. So two things would be important, would be those two things, time and the resources. And then it becomes a matter of what your desire and level of enthusiasm is. But if you don't have the time and the resources, you can't do it.
Well, the next question is, what are the qualities of a good mentor? And how do we choose a mentor? How do we approach someone for mentorship?
Yes, very, very important. So the qualities of a good mentor, I would put right at the top of the list, time. That person must be willing to give of their time, because all other things being equal, you're gonna be needing to get some of that mentor's time. And usually these are busy people. They're usually busy academicians or busy professors and so on and so forth. So time is number one. Second thing is that they must have a good track record of mentorship. So you ask and find out, who have they mentored? Who have they trained? Who have they supported over their career? And go talk to those people and find out how successful that mentorship relationship was. So number one, time. Number two, that person must have a successful track record of doing this, and they have the connections and the wherewithal to do it.
Nelson, that was great. Thank you. It was wonderful. I think, Sandeep, we need to move on. Maybe we get Yoko to go next. As Joachim, we can always play afterwards. Nelson, thank you for being present for this occasion.
All the very best. I wish you all the very best and success. Bye-bye.
Bye-bye.
So our next speaker, who does not require any introduction, she is President of Asian Congress of Neurosurgical Neurological Surgeons and Professor and Chair of Neurosurgery at the Department of Uito Health University, Professor Yoko Kato from Japan. She will talk about why women should become a neurosurgeon. Dr. Yoko Kato.
Can you see my slide?
Yes, we can. Please
Oh,
continue.
thanks. Thank you for invitation. And Nelson was the excellent talk. And thank you very much. And Salman Sharif, very nice to see you again. Thank you very much for inviting me. So it's quite a difficult, the title, the SEMA, which you gave me. So, because I don't think recently the genderless, so that means is it's quite difficult to separate men and women. So, but anyway, already the Nelson talked a lot. It is a little bit overlap my talk. So it's physical hard work. Already he mentioned, and it's emotionally hard work. Both we need some ability. A strong work ethic is important in all field, and also neurosurgery is no exception. So the 5 qualities we ask. So the motivation, honesty, willing to learn, ability to problem solve, ability to handle stress. So those 5 components is very, very important. And also the quality of the great neurosurgeon. So it takes a little bit a long time, but I think from the medical student time, so I think you should accumulate, and just you can learn from your mentor. And I think then I think those qualities that you can receive. So especially the organization, sometimes the female is a bit, I think less the male, I think. But the team player and the other things is almost, I think we can achieve in both sexes. And also the research work is very, very important as a neurosurgeon. So application of evidence-based medicine and the accreditation of the Council for the graduate medical education, and the required to demonstrate academic reproductivity and also mastery of the EBM, the principle, to update the novel knowledge on current or future practice. And we need overall training, the culture with the faculty, mentorship, and the provision of the time, the resources of research activities. And the professional perception in the neurosurgery, the adequate time for personal development, and also the challenge at work and the good work-life balance, what he mentioned, and the sports, understand extra work hours. So this is one of the most important things, I think, the family assistant. And uncertain the future earning and the health, the care reform. So I belong to the Asian Congress, so the education is quite important, I think. So this is which we had some for 5 days educational course in Zimbabwe, Africa. So Salman Sharif, that he attended and taught us a lot about the spinal lesions. He's talking now. And also, I think you should have friends, make friends. It's very, very important. So when you go to the developing country, I think very unique experience. Of course, the lack of the equipment, the almost zero start, nothing. They did not have anything. So at that time, we hired of the sophisticated microscope from the company, and we did demonstrative surgery. But I think the developing countries, the people, the male and the female, they overcome their some lackness. So, and also this is very interesting, the video, because India is a very conservative countries, I think, because I visited so many times. Yeah, but I think this is a inauguration of the Indian Female Neurosurgeons Association. So in 2016, almost already 8 years back. So I think every female resident, especially from the medical student, so they want to eager to learn, and also the support save the patient life. So I think the female that we can just we recognize, and also we encourage them, so they can do many things for the patient, I think. So during the COVID-19 the time, so we did so many the webinar series, and the women's activities, and also the foundation, I think, the seminar and the winter seminar, the webinars. So we did continuous the educational course, and then we can have chat, and also not only the discussion, but also we can have female medical students and doctors. Especially the Pakistan is very high the level because so many the medical students is association is organized in Pakistan. So these are some the educational in the future. There are some target. So this is one of the residents that did a surgery. So this is an ACOM aneurysm. Maybe some of you understand. So recently, of course, the less invasive. So endovascular treatment is much popular than the open surgery. But sometimes we need to do the classical type of the open surgery. So this is just 6 years resident. He was dissecting of the cerebral fissure, and through the left anterior approach. So the ACOM aneurysm is located just in the midline. So now we can expose of the aneurysm here. So aneurysm is a double dumbbell shape, and the wall is very thin. So I think the step by step. So this is I think of course the man and the female, the both can do. So this is another case. This is a bypass case. So this is a preoperative amila image. Recently, the 3D the image is very getting popular because we want to do some target the bypass surgery. That means is a very small anatomy. We hit the exact place of the bypass. So this very small, the tiny, the craniotomy, and we harvest of the. So maybe we don't have time. So we harvest of the STA. Superficial temporal artery, then we can make a bypass, the biggest, the recipient, So you should finish the bypass surgery at least in the 30 minutes. So you need some training, so daily training. So because anywhere you can do the training. So this is almost a 20 times magnification under the microscope. So the very precise work is, I think, the male and the female doctor, the neurosurgeon, must do, can do, I think. So this is the Asian Congress, already I mentioned. So these are some webinars which we did. And this is some alumni association, the webinar. So we did a continuous the webinar, and we can discuss the recent the knowledge and the skill among our colleagues. So this is Women Neurosurgery in Asian Congress, and also the how can we balance the for women? That is the one of the best concern, I think. So I think the promote awareness that equality of the sexes, and promote training in the neurosurgery such that women are the majority, promote female leadership in academic positions. And maybe I think the surrounding people, especially the male, the doctor and the mentor, can support the female, I think. So offer accommodation or higher salaries for women who work on the academic workplace. So I think if it were not for the effort of these exceptionally strong individuals, the wing of the women in neurosurgery would not have advanced to its present day status. So this is some video which I visited Nepal. So this is a medical student, some association, all medical students. And society present is Miss Hira. He invited all the medical students. So we had a very nice lecture and also the summer communication with them. So I think encouragement from the medical student is very, very important, I think. So this is some association of them, the medical, the nursing association. So finally, just the ethical issue for neurosurgeon, a good person versus a good neurosurgeon. So these are deepening the self-awareness and becoming a better influencer, the leading with the honesty, the improving the coaching skills, developing emotional intelligence. So these are the very important. So do no harm. So it's he is Henry Marsh. He is a very, very famous neurosurgeon. So he is a father of the ethical dilemma issue and provides the concept of the do no harm in such case of hopeless care in neurosurgery. So we should keep in mind. And also, this is Charles Tale from Australia. He saved the young pianist, the life. So 24 years pianist with brain tumor, given 6 weeks to live. But after the tail surgery, the days later, he was back at the piano. So we never give up until the end. So those the short the word, the flexibility and the capability and the patient, the welfare and the humanity, be strong and touch the confidence, concentration. Those are very important, not only for the female, but I think some of them is good for men, I think. So I think still the challenge, I think that you should have a very bright future, I think. And also maybe in the next 10 years, I think the treatment of the neurosurgery is much changing, I think. So I think also that you can do both the research and the clinical work. So my best wishes to the future, the bright career. Thank you very much.
Thank you very much, Professor Kato, for the presentation. Our next speaker is Professor Joachim Ertel from Germany. He is the Director of Neurosurgery at the University of Saarland. He will be talking about why you should become a neurosurgeon. Thank you.
We will have discussion after this talk. Volume, please.
Hello. It's a pleasure for me to be part of this event. My name is Joachim Ertel, and I'm the Director of Neurosurgery at the University Hospital in Saarland, Germany, and I'm Professor of Neurosurgery at the Medical Faculty of the University of Saarland in Germany. The topic of my talk is why to become a neurosurgeon. I'm from Europe, Southwest Europe, Hamburg, a small city close to the French border. And you see that we are 1 hour from Frankfurt, Strasbourg, and Luxembourg by car. This is our university campus on the upper left. And all the way up on the hill is the neurosurgical department together with neurology and psychiatry, the so-called Nervenberg. On the right, you see the Department of Neurosurgery. We do like 3,500 procedures, about 33 colleagues, 4 theaters, and about up to 94 beds. So why to become a neurosurgeon? Or why to become a surgeon first? To do something with your hands. Not to think about, increase in pill dose from 40 to 60 microgram. And for the feeling to cure patients. So why do you want to become a neurosurgeon, not a general surgeon? Well, it's a wide variety of disease, treatment from the neonatal status up to the very old patient, with the surgery of delicate brain structures, and it's also surgery of spine indications with application from minimal invasive techniques with the endoscope up to screw osteocentesis and scoliosis treatment. Neurosurgery is actually a very old surgical discipline. First craniotomies were reported 10,000 before Christ in Africa, and craniotomies were found basically all over the world between 6,000 to 8,000 years ago. The technique of neurosurgery did not change much until the 15th century. You see here the Christian report when there was surgery done in a child without any analgesic, without disinfection. And due to this high surgical trauma, there was a very high mortality. In the beginning of the 20th century, there was the foundation of modern neurosurgery. And one of the founders was Felix Krause, and he described in 1908 one of his first presentations, one of his first surgeries. And he said the following thing: the surgical procedure was tremendously impressive. The brain tension was so high that although the assistant used a spatula and pulled the spatula with all his force and with both hands, he was only able to create a finger-wide space. So you can think about when you use all your hands, both hands, all your force, how much trauma there was created by these early brain procedures. And another aspect of brain surgery is the development of endoscopy. So one of the founders of the first endoscopic techniques was Bozzini, a physician from Frankfurt, Germany, and he developed a so-called Lichtleiter. So basically a system with candles and tubes used as a speculum in gynecology and urology. The first electrical light source And the lens system was used by Maximilian Karl Friedrich Nietzsche in Germany, and he used this for gynecology and urology. Better illumination, larger visual field. The first brain procedure with an endoscope was done by a urologist, Victor Lespinasse. First endoscopic surgery in the ventricular system. He coagulated the choroid plexus in 2 children, and one child died immediately, and the other child survived 5 years. The founder of modern neuroendoscopy was Sir Walter Dandy in the Johns Hopkins Hospital in Baltimore, who worked. And you see one of his early publications from 1922, how to approach the brain ventricles and how to position the patient and everything. So basically, this surgical atlas is still valid until today. Then the first endoscopic third ventriculostomy was done in the Mass General Hospital in Boston in 1923 by William Mixter, and this was an encouraging situation. So in the beginning of the 20th century, there was a larger, a big enthusiasm about endoscopic procedures and neurosurgery. So Putnam and Scarf did a much larger number of patients, but they found in the first larger series that there was a mortality of 50%. So this technique was not further followed. 60 to 70 years later, it came to a renaissance of the minimally invasive techniques in neurosurgery. Because of the development of microsurgery, CT, MRI, modern intensive care techniques, and because of the invention of rod lens scopes and a cold light fountain. Few centers in Germany focusing on this technique. So there was Professor Bauer in Hellwig in Marburg, Gab in Greifswald, and Panetsky in Mainz. The term minimally invasive neurosurgery was coined in 1991 by Professor Bauer and Hellwig, and they described basically their neuroendoscopic techniques. Here you see one of our publications about minimally invasive neurosurgery, and you see the various techniques from Marburg, Greifswald, and Mainz. This is a modern setup about a minimally invasive neurosurgical technique. And here you see the application of the endoscope and the semi-sitting position. So what does it? So here you see the resection of an epidermal tumor in the posterior fossa. It's then into the fourth ventricle. And in the lower part, you see now the application of the 30 degrees and a 70 degrees endoscope, which allows you to see at the tentorium remnant tumor tissue, and you can appreciate the possibility of resect this tumor tissue with the angulated optics. And this is the video. You see here now the clipping of the aneurysm, of the anterior communicating artery aneurysm. We have a left frontal approach. And then after clipping of the aneurysm, we control the microvascular perfusion with a microdoppler. And then we see here the carotid artery on the left and the optic nerve on the right. We go through the opticocarotid window. We go to the basal artery trunk. And we use the microscope to identify the aneurysm at the basal artery tip. And you see that our image is limited. And now we bring in the 30 degrees endoscope. And we see a completely different image. This is the endoscopic image now, and we see everything. You see on the left the oculomotor nerve. You see on the right the oculomotor nerve. You see at the basal artery tip the aneurysm. you see the posterior cerebral artery, you see the superior cerebellar artery and the basal artery trunk. So with the use of the 30 degrees endoscope, we can now apply the bayonet-shaped straight clip and then do the endoscopic final inspection. So here's the clip application with a microscope. And then after clip application, we go in with the 30 degrees endoscope to control. Much better view with the minimally invasive techniques. Another option are tumors. Here you see the endoscopic resection of an anaplastic astrocytoma in the left lateral ventricle. You see that the diameter of the tumor is maybe 5 by 8 mm, so very small tumor, and the tumor is resected in the piecemeal fashion within grasping forceps. You see the diameter of the grasping forceps might be 1.5 by up to 2 mm in diameter. This is one of the most impressive applications of the endoscope. This is an endoscopic third ventriculostomy in a child with a tumor in the aqueduct. So one of the most delicate structures in the brain. So we do the endoscopic third ventriculostomy at the floor of the third ventricle. Do the perforation. Do the inspection. You see the basal artery. And then we do the endoscopic biopsy. This is the aqueduct, one of the most feared structures to do surgery on because there's a very high density of eloquent structures around the aqueduct. You see here with a small grasping forceps, a biopsy is done of this tumor which blocks the aqueduct. Just to see the diameter. The diameter of the aqueduct might be 3 millimeters. So the grasping forceps might be 1.5 millimeter in diameter. So why to become a neurosurgeon? It's a very old, but however, very fast developing profession. It's a highly technical, demanding profession. It covers everything from delicate, minimally invasive surgery to major fusions. If your interest is to start from basic research up to do major challenging procedures, neurosurgery is a discipline to go for. Thank you for listening.
So such a nice talk by Dr. Joachim. So now we would like to request Dr. Sandeep Vaishya and Dr. Saad Akhtar Khan from Pakistan to moderate the question answer session, please. Dr. Sandeep Vaishya.
Yes, so there are first few questions for Dr. Yoko. And so there's one question that what advice can you give a student who wants to be a neurosurgeon but draws back because of the fears from the fact that they will have less time for family and extracurricular activities?
Yes, that is I don't know. Is it a disadvantage or we could say, but I think maybe suppose or some other supporter, I think that we can help during that time. I think that now is the time, the work time is quite very severe limitation. So I think that many of the people can have collaborate and task shift or task share. So I think that we can have the more the time for the family during that time. I think that is my suggestion.
So there's another question that women willing to pursue a career in neurosurgery are often victims of sexual harassment. What advice can you give to young female neurosurgeons facing this problem?
Can you once again, please?
Yeah, the females pursuing career in neurosurgery are often victims of sexual harassment. So what advice can you give?
Sexual harassment.
Yeah.
So during our period, I think because we had a lot, but I think of course it's that the time is changing. I think some sexual harassment, the committee or many some section that has such a the problem solved. I think. But I think you should have a strong motivation to become a good neurosurgeon. That is the most important. And also the mentor can encourage the female doctors, I think.
Shaswar, would you read out the next question, please?
Our next speaker is Professor Michael. Sorry, sir, did you ask for reading the question?
I thought that we are continuing with the question answer session. So there are a few more questions.
Yes,
so there's one question. Hi everyone, this is Dr. Saad. So there's one question regarding pursuing neurosurgery. This is by a medical student in Pakistan. So this question is about pursuing neurosurgery as an IMG outside Pakistan. And the question is that, you know, there's not a lot of residency programs take IMG. So, you know, maybe one of you can answer this question. Maybe Professor Nelson can answer this if he's available.
Sorry, Nelson is left.
So IMG's neurosurgery.
Saad, what do you think?
I think so. Yes. Previously, previously IMGs was considered as brown, but now I think even you know, there's a lot of programs that have stopped taking IMGs, so it's getting difficult. The number of calls have reduced, and you know, for them even now diversity has changed to, you know, colored people other than brown, I guess. So, you know, yeah, it is difficult, but it's not impossible. So you need to put in the work. I think you need to have research electives, and you need to maybe work as a postdoc research associate there, maybe work your way up. So it's difficult, but it's not impossible.
And I think mentorship is very important, as Yoko and Joachim both said, you know, so that is essential. Without that, I think it's very difficult to get into good programs.
There's a lot of questions. I mean, do we continue?
No, we need to move on. But Sena, would you like to comment since you're representing Joachim?
Yes, thank you. So as from the female perspective as a resident nowadays, I would say that, of course, it depends a lot on where in the world you are living and what the general terms for women are in the country you live in. And of course, in Europe, where I work, we are quite privileged, and we know that, and still there are structural challenges for women compared to men, and also society society reasons why there might be issues or hurdles, but still it very much depends on your own lifestyle and your own wish and enthusiasm to pursue a career in any medical field or a general working career as a woman. So I think there should not be any reason to not start or try to start a career in neurosurgery. So it's very rewarding in so many ways, and still, if there are challenges, it only builds resilience. And yeah, if you're willing to try it and you have a lot of passion for the field, go for it and try your best to get in a good program, and search for companions, other female surgeons or doctors, and if there are any struggles, talk about it and try to find companions that help you through your struggles there, and then you will be rewarded with a very challenging but also very happy career.
Thank you, Sena. Sena is actually senior resident with Joachim in Hamburg in Germany. Yoko, your comments?
Yes, thank you very much for your very the deep thoughts, I think. But I think not the challenging. I think as a neurosurgeon, I think you should have a confidence, because the surgeon needs the skill and also the knowledge both. So I think step by step, year by year, you can accumulate year and confidence. So then you can have some good results. And then I think it's quite maybe difficult to harassment, such as a situation just a female. I think it's very important. You should have the confidence as a neurosurgeon. That's a very, very important thing. That's my comment. Thank you.
Totally agree. Thank you, Yoko. I think we need to move on as we're running late. So can we introduce Michael? Thank you, Yoko. Wonderful to have you here.
Thank you. Our next speaker is Professor Michael Felix. He's a world-renowned neurosurgeon from University of Toronto, Canada. He is going to talk about the evolution of a spinal cord injury. So, Felix.
Hello, I'm Michael Felix, a professor of neurosurgery at the University of Toronto. It's a pleasure for me to speak to you about the modern management of spinal cord injury, which has been an evolution. And I'm pleased to take part in this World Neurosurgery Students Conference. I have no disclosures that are particularly relevant to the talk, but I have spun off a biotech company which is being managed the principal investigator on a number of clinical trials in the area of spinal cord injury, and have received various forms of grant support. I just want to acknowledge the organizers of this conference and Professor Sharif. This is where I work in Toronto, which is a beautiful city. Criminal Neuroscience Center is a part of the Faculty of Medicine at the University of Toronto, and home to the neurosurgical and neuroscience programs. And this is a wonderful team that I work with, and I just want to acknowledge them. So spinal cord injury comes in many forms, and these are very, very sick patients. Spinal cord injury has a huge impact on individuals' independence and quality of life. Here's a case example of a 39-year-old man who dove into shallow water. And this is a CAT scan reconstruction. This shows significant dislocation forward of the 4th cervical vertebra and the 5th cervical vertebra. This is related to a bilateral facet dislocation. This is the MRI scan, mid-sagittal T2-aided image showing severe contusion and compression of the spinal cord. And this individual had a very severe level of injury with no motor or sensory function below the level of the C4 level, so-called Asia A level of impairment. So what's our treatment approach in the modern era? So I'm going to cover 3 fundamental areas. So one are some of the principles of acute management, critical care principles, including hemodynamic management. I'll talk about this concept of time as spine, so the time critical nature of early decompression, and I'll talk about the role of steroids and emerging strategies, including Riluzole. I'll briefly discuss neuroregenerative therapies, as well as approaches to bypass injured neural circuits. So 3 learning objectives are to understand the concept of time as spine, so the time critical nature of acute intervention in spinal cord injury, to list some of the key neuroprotective strategies currently under investigation, and to discuss key concepts related to regenerative strategies for spinal cord injury. In terms of early management, time of spine is a critical concept, and the idea here is that early neuroprotection mitigates secondary injury mechanisms and enhances outcomes, and this forms the backbone to a multi-pronged approach to spinal cord injury care. So here we have our patient with this mid-cervical MRI study with a very severe bilateral facet dislocation. So what does this actually look like? And this is not this person's image, fortunately. This is a post-mortem mid-sagittal section from the collection of Professor Rauschning. And this shows severe instability of the cervical spine, bilateral facet dislocation. There's compression of the cord, mechanical instability, and there's a contusion with hemorrhage within the cord. Now, this is animal model work, and here we've injected the vessels of the spinal cord post-traumatic injury in this rodent model. And it shows a disruption of the central vasculature, and this results from mechanical disruption of the vasculature. And then surrounding this area is this loosened area, and this is the so-called ischemic penumbra. And in this zone, there's a progressive degradation of nerve fibers here stained on a confocal micrograph with neurofilament 200. And then going back to the human situation, this is a human post-mortem mid-sagittal section of the spinal cord. The hemorrhage is now resolved in the chronic phase, and there is a cavitation surrounded by the perilesional scar tissue, which includes the astroglial response. And then there's been an anterograde and retrograde degeneration of the nerve fibers. So this shows the evolution of the pathological events occurring in spinal cord injury, and each one of these time points represents unique opportunities and challenges for management. So the cartoon level, so these are some images from our review paper in Nature Neurology. And this shows the concept of the acute injury with mechanical injury, hemorrhage, a disruption, necrosis, and early onset of inflammation. And then in the subacute phase of 2 to 4 days after injury, there's a further ongoing inflammation, and there's the beginning of some of the reparative processes with a clearing of the debris. But this represents a continuing firestorm of inflammation. In addition, there's secondary injury events, including the release of oxygen-free radicals. And then in the intermediate and chronic phases of the injury, months after the injury, there's an absorption of the necrotic and apoptotic cell debris. There's this cavitation in the perilesional scar, and there is a demyelination of some of the remaining axons, as well as anterograde and retrograde degeneration of these axons. Now, spinal cord injury, in particular cervical spinal cord injury, results in profound disruption of the sympathetic nervous system. And the main nerve cells in the intermediolateral cell column of the cord that control cardiac function and blood pressure are in the upper portion of the thoracic cord. And so there are significant cardiovascular complications that occur after spinal cord injury, including neurogenic shock, bradycardia, cardiac arrhythmias, and the more chronic phases, autonomic dysreflexia. And venous thromboembolism is also a significant issue that can occur. So patients with an acute spinal cord injury should be transported as soon as possible to a specialized facility, and they should be managed in an intensive care unit or similar setting with appropriate monitoring. The neurological evaluation should follow the Asia standards, and I alluded to these. So this is A, B, C, D, E. And A is a complete injury with no motor sensory function below the level of the injury. B is a motor complete lesion, but there is some sensory function that could be spared, and it's important to check the perianal sensation in S4 to S5 area. C and D are incomplete lesions with increasing degrees of motor recovery, and an E patient is a patient who's had, in essence, a spinal cord concussion within a complete recovery. And then one uses a standardized neurological classification of the motor examination and the sensory examination to very accurately assess the level of functioning. So again, the hemodynamics are important after acute spinal cord injury, and the autoregulation of spinal cord blood flow is disrupted, and this can result in neurogenic shock. And the treatment is volume expansion and inotropes, including dopamine. And this is supported by guidelines. And so the prevention of spinal cord ischemia is critically important. Acute trauma, including spinal cord injury, sets off a hypermetabolic, catabolic cascade, and it's important to feed patients, and their energy requirements are greater. And it's estimated that you need to give people with an acute spinal cord injury about twice the normal caloric requirements. And as I mentioned, spinal cord injury increases the risk of thromboembolic disease, and it's important to use DVT prophylaxis, including low molecular weight heparin. Now, from the concept of time of spine, there's a strong rationale for early surgery to decompress the spinal cord and to stabilize the traumatically disrupted spinal column. The idea here is to limit these secondary injury events. So this is supported by robust preclinical data from the basic science work, and also by this a clinical trial that I led now a decade ago called the Stasis Trial, where we showed that the odds of having a significant recovery of neurological function were almost threefold higher if patients had surgery within 24 hours. And this subsequently spawned clinical practice guidelines that provided the recommendation that early surgery be the preferred practice option. And more recent data, including this large study in over 1,500 patients by our group published in Lancet Neurology, supported this role of early surgery. And so this is now spawning off next steps. And so there's further knowledge translation that is occurring in terms of updating the guidelines to further strengthen the recommendations around early surgery. And there's a lot of interest around the concept of ultra early surgery, so trying to go in within a few hours after injury. And there's a lot of debate within the neurosurgical field on the appropriate techniques to use for decompression. Methylprednisolone is a powerful corticosteroid, and it's been studied in a number of acute spinal cord injury studies. And we did an updated meta-analysis, which is shown here. And here are these different clinical trials that were done. And if you look down here at the black diamond, this is the mean and the 95% confidence interval, and this is favoring methylprednisolone. So these are small, relatively small effects, but this can have a big impact, particularly in patients with acute cervical cord injury. And fortunately, the drug itself is quite safe, and if anything, the risk of mortality is slightly less in patients receiving corticosteroids. And so based on this, it's felt that intravenous methylprednisolone is considered a valid option to be used in patients with an acute spinal cord injury. Now, what's emerging, and I'll talk in particular about the sodium glutamate antagonist riluzole, and there's a lot of interest in systemic hypothermia and cooling. The drugs here in brackets have been studied and found to be ineffective, and GCSF is a pro-inflammatory cytokine that mobilizes mesenchymal stem cells. This is being looked at in early phase clinical trials in Japan. So this film will just briefly outline the concepts that we're studying with riluzole. Here I'm modeling a subaxial cervical burst fracture that initiates the primary injury. There's an expansion of the primary injury through mechanisms of secondary injury. At the microstructural level, one has voltage-gated sodium channels on the neurons and at the nodes of Ranvier of the axon. So there's a rapid influx post-trauma of sodium. Cell swelling occurs due to influx of water, and then calcium entry occurs through reverse operation of the sodium-calcium exchanger. And then this results in a pathologic release of the excitatory amino acid glutamate. And this triggers what's called excitotoxic cell injury. This is a critical mechanism that occurs in brain trauma, spine trauma, as well as in stroke. So the idea that we're looking at in clinical trials is to do early surgical decompression and stabilization following the time of spine principles of Stasis, and then we're administering riluzole to try to block the influx of sodium. This has been supported through early phase clinical trials that we led, showing in the comparison between blue and red, improved changes in the age impairment scale, as well as improved motor recovery is shown here. So on the y-axis are motor scores. These are in cervical patients post-injury, and the patients getting riluzole had improved recovery. So this was a small unblinded study, and this kind of set the stage for a large phase 3 randomized trial that we've now completed, and this is now being written up for presentation. In parallel with the studies in traumatic spinal cord injury, there's a form of non-traumatic spinal cord injury called degenerative cervical myelopathy, and we actually found some interesting positive effects of riluzole in this patient population. This was published last year in the Lancet Neurology. Now, in terms of neuroregenerative approaches, and here again, we have the chronically injured spinal cord, inhibitory molecules limit axon growth, and it's a hostile cellular environment. And so regenerative strategies have been studied, including cellular therapies. And the idea here is to try to replace lost cells. These might provide trophic support through growth factors and potentially immunomodulate. They don't tend to produce a lot of scaffold support, and sometimes biomaterials can be used in combination with stem cells. And so the three cell types that have been most extensively studied are neural stem cells, Schwann cells, which are peripheral glial cells in the peripheral nerve, and endogenous stem cells. This is an article from Lancet Neurology, supported by some other publications from our group, which we summarize some of the human clinical trials with neural stem cells. And these have shown safety and feasibility, and have set the stage for more advanced neural stem cell trials, which are now in the planning processes. There are amazing technologies that are occurring with regard to bioengineering of these neural stem cells, including genetic engineering to express growth factors, such as glial-derived neurotrophic factor. This is some work published from our group in Science Translational Medicine with the use of this kind of strategy. And then in addition, there's a lot of interest in endogenous stem cells, which are in the center of the spinal cord, potentially harnessing this regenerative potential. There's also a lot of interest underway in looking at molecular strategies to inhibit some of the inhibitory molecules in the spinal cord. One of these is a no-go that's expressed on neurons, and when it's activated, this inhibits axonal regeneration. And there's a phase 2/3 randomized trial that's just completed enrollment in Europe. And there's an ongoing randomized trial looking at repulsive guidance molecule A and specifically monoclonal antibodies to target this. There's also a lot of interest in the use of bioengineered scaffolds, and in vivo therapeutics has just completed a phase 2 clinical trial. There's also a lot of interest in the use of electrical stimulation to bypass intraneural circuits. And the idea here is you can use either brain-spinal cord interfaces or epidural spinal cord stimulation to activate these neural circuits. And then in combination with advanced rehabilitation protocols, this is showing a lot of promise. So where are we in 2022? Well, time is spine. Early surgery is critical. Hemodynamic management is important. Steroids are an option. Other neuroprotective strategies, including riluzole, are emerging. And electrical stimulation is showing considerable promise to activate neural networks. So this slide gives a sense of where we'll be in a decade from now, 2032. I envision that early surgical intervention for spinal cord injury will become the international standard of care, and that we'll be optimizing techniques. Several neuroprotective options and regenerative options will become available. And I see that increasingly we'll be looking at personalized approaches to individualized care based on knowledge of genetics and genomics. So it's really a promising field for medical students to consider as a future career. And on that note, I'd like to conclude, and I'm happy to take questions.
So we'd like to have question and answers. Dr. Sandeep and Dr. Saad Akhtar will moderate the session, please. Dr. Saad?
So up till now, I don't think, I think all the participants were busy in getting the presentation. There are no questions up till yet for Professor Michael.
I think there's only one question. It's not about spine, but there is a question that why is neurosurgery so competitive and difficult to get in despite more hands-on needed in the field? That is one question for Michael.
And there's another question that how the role of spinal cord the role of evacuation of spinal cord hematoma, and how do you manage CSF leak post-traumatic?
Okay, so I think that neurosurgery is a great profession. It's always been a very demanding profession, and I think that becoming a neurosurgeon is a little bit like training to become an Olympic athlete. It's not for everyone, but I think that the rewards are that you can make an impact in the lives of some of the most vulnerable patients. And the reason it's demanding is that the skill sets and the knowledge that are required are quite substantial. And so there's a significant knowledge that's required in general anatomy and neuroanatomy, in neurophysiology, neuroscience, and then there's also the technical dexterity. And as Professor Kato mentioned, under fire and while you're treating very complex patients, and also being empathetic to patients and families under very stressful circumstances. And so this has always been a demanding area, and that's just kind of the nature of the way this is. It also places significant demands on the individual themselves. Having said that, it's also very important as a neurosurgeon to also be a good human being. And as such, it's also important to have balance and to be able to take time for yourself, to be clear in your mind. And there are different ways to do this. So having outside aspects of enjoyment are important. And it's also very possible to have a balanced family life and to enjoy this. And this is also very important because by having these qualities in your own life, this can allow you to be a better doctor and to be a better neurosurgeon. So, I think those are perhaps some personal perspectives in terms of neurosurgery. And I think, my comments are that, yes, it's very demanding, but I think you'll find that if you're able to meet those demands, that it's a very rewarding career. And then there was kind of a technical question related to the evacuation of the hematoma within the injured spinal cord. And this is a concept that has sort of been hot and cold over time. And in fact, early in the 20th century, there were some early investigators that postulated that maybe evacuation of the hematoma could be of benefit. I would say that in general, this has not been something that has been widely used in neurosurgery for fear of causing injury to the cord, but there is now some renewed interest to perhaps cautiously investigate this. So I would say that this is something that is under very cautious investigation right now.
Another question, Mike, I'd like you to answer is that neurosurgery itself can cause toll on your mental health because 80% of patients have poor prognosis. Is it really true?
Well, I would say I saw that question also, and that we're able to help many patients now that you're looking at. So I would say the outcomes for patients with severe brain trauma and severe spinal cord trauma remain challenging, but the outcomes are substantially better in neurotrauma than they were even 20 to 25 years ago. And then also the outcomes for many other conditions, including tumors, vascular issues, degenerative issues of the spine, have substantially evolved. And in general, when I see patients in my clinic, I would indicate that in general, 80% of patients have an excellent result, and that at minimum, we're able to halt deterioration in almost all patients. So I would say that the outcomes in general in neurosurgical patients are excellent. And this is actually one of the very positive features of our profession, is that we can make a very positive impact in most individuals' lives.
So do we have time for another question? Because there's one question about research in neurosurgery.
Okay, last question. We're running late.
Well, neurosurgically is an intrinsically academic specialty. And I think when possible, research is an important part of the training of a neurosurgeon. Not all neurosurgeons will be able to continue doing research, but it's important to be aware of the research so that you can continue to evolve this. And it is an option for some neurosurgeons in academic practice to continue to do translational research. So it's one of the options that does exist.
Sheshawar and Sidra, I think we're going to move on. Thank you, Mike. It was brilliant.
Thank you, Professor Felix, for that. It is my great pleasure to invite Mr. Nikolai Pev, my own mentor, for this talk. And he will be talking about, he'll be specializing in complex spinal surgeries at the Belfast Trust, and he will be talking about the Lumbosacral Anatomy and its clinical approach. Thank you.
Thank you so much for the introduction, Shas, and it's my great pleasure to be with you. Please excuse me for the late start. The weather is great in Northern Ireland, which is not very often, but lately maybe we are the great winners of the global warming. We have so many nice days lately, so we'll see what's going to happen in the next years. We may start hosting not only scientific events, but maybe also holiday makers. So let's see. Okay, let me start now here. I'm gonna share my screen. Can everybody see that?
Yes.
Can you see my screen?
Yep.
Yes, sir, we can see that.
Okay, right. So I'm going to talk to you about lumbosacral anatomy. Anatomical talks, they're like evergreen in medicine. If you know anatomy well, you can progress not only in the surgical specialties, but in any kind of surgery, or any kind of specialty, any area of the modern medicine. So anatomy is your base. So know anatomy, and then it will be good. I hope when I finish my lecture, you will not be in the group of that Italian physicist who said that before the lecture, he was confused. After the lecture, he was even more confused. So hopefully I'll leave you less confused. So speaking about the lumbosacral anatomy, you have to know that every vertebra has certain elements. And these elements, they change their features starting from top to bottom. So you have to know the vertebral body and the disc, the transverse process, the spinous process, the pedicles, lamina, lateral mass, and then you see the intervertebral disc, the joints, and then the facets and also the ligaments. So we'll say a few words of each of these elements. Obviously, I cannot cover everything within the limited time that I have, but I'll try to give you some insight, and I'll try to give you some elements with clinical importance. So vertebral column has a very important function, transmits the weight of the trunk up to the lower limits of limbs, and provides stability, surrounds the spinal cord and protects it, and its attachment for many important structures, muscles, ribs, and it's important for the mobility and for the stability. Two contradictory functions, mobility and stability. Three main areas. You have cervical region, thoracic region, lumbar region, and then a fourth sacral and coccyx region, which is the base of the spinal column. So the three main areas are different with respect of their functioning. So we have a cervical spine that is in lordotic shape, and it's the best range of movement in the cervical region. But unfortunately, if you have a lot of movement, you have more chance for injury. So that's why the C-spine is more prone to injury. You have thoracic spine, that is with great protection. It's the most stable part, least range of movement, but obviously is more stiff. Then you have the lumbar spine, where there is a balance between protection and range of movement. And I'm going to focus on that part later on. So important elements of the lumbar spine and any part of spine, apart from the bony anatomy, you have to know the ligamentous anatomy. So let's start with the ligaments. Anterior longitudinal ligament is one of the strongest ligaments. Starts from the neck and runs down to the sacrum. Attached very strongly to the vertebra and intervertebral discs, and one of his main functions is to prevent hyperextension. The posterior longitudinal ligament runs on the opposite side of the vertebral body. It's smaller and it's a narrower and weaker, and it's attached to the intervertebral discs. Its function is to prevent hyperflexion. We have to mention also the ligamentum flavum, or so-called yellow ligament, which is covering the spinal canal from posteriorly in between the laminae. And it's one of the strongest ligaments, and its function is also to prevent hyperflexion, but also to protect the spinal canal from posteriorly. It is stretching with forward bending and recoils in erect position. The intertransverse ligaments, they are weaker, but because there is a big leverage, they are far from the axis of rotation. They still are important for the stability of your spine. And the same is for the interspinous ligament and for supraspinous ligaments. So you can see here on that slide that the three main types of the vertebral bodies are compared: the cervical, the thoracic, and lumbar. And you can see that the chunkiest ones are the lumbar ones, because they have to withstand a lot of weight, and that's why they are stronger, they are bigger. A diagram that is presenting the different features of the different parts of the spine and the vertebrae. You can see that in the cervical region, small vertebrae, which go bigger and going towards the lumbar. The transverse process is following the same pattern, and it's long to provide big leverage and respectively big stability. And same is with the spinous process as well. So important for the anatomy of the lumbar sacral region is also, and for the other regions, of course, is the facet joints. They contribute for the range of movement. They are weight bearing and they distribute the forces. And these are synovial joints, so they degenerate like synovial joints as well. Maybe you will hear in the clinical practice pars interarticularis, or just pars. I remember when I was a student, it was very confusing for me, where is pars and what is pars. So this is what's pars, the area between the superior and inferior facet. And it is a relatively weak area that sometimes will sustain stress fractures, and that will cause problems to your patient. So it's good to know where is it. An intervertebral foramen, important structure that will allow the nerves to leave the spinal canal. The boundaries of the intervertebral foramen are the two pedicles above and below, the disc in front, and the facet posteriorly, together with all the ligaments. With degeneration and with different other conditions, this may become narrow, and that may cause compression of the nerves and respective clinical presentation. Intervertebral discs, very important. You have 23 intervertebral discs. Just bear in mind, there is no disc in between C1 and C2. I just recently got a report saying C1C disc. Actually, it was a pseudo fracture with panos formation, but somebody read it as intervertebral disc C1, C2, which is a mistake, obviously, and you should not do that. The function of the intervertebral disc is mainly as a shock absorber. It allows the spine to bend, and it is distributing the uneven forces, and like that is preventing damage of the spinal canal and the spinal column in general. Two main parts. If we talk about the clinical anatomy of the disc, you have the core, which is known as nucleus pulposus, and it's gelatinous and acts like a rubber ball, which is full with water, about 60–70% of water comprised. And then you have outer rings, which is known as annulus fibrosus, with multi-layer fiber coating that is going cross-directional, and it is absorbing the compressive forces of the core and from the above and below as well. So the disc, together with the up and down adjacent vertebra, and together with the facet joints and the capsules, and also the connecting ligament, is presenting the motion segment, which is the basic functional unit of the spine. So it is important for you to understand and to know that. The motion segment and the functional unit is important for distributing of the forces. You can see here in the lumbar region, about 80–90% of the forces are going through the anterior elements of the spine, and only about 10–20% through the posterior column. It is completely opposite in the cervical region, for example. About 80–90% go through the posterior column, and then 10–20% anteriorly. So it is important for the biomechanics of the spine to understand that and to know it, and to know the clinical implication of that, which will be discussed later. So intervertebral disc is very important for the functioning of the spine, and collectively the discs present about 25% of the height of the vertebral column in young individuals. Lately, with aging, that gets less, and you can get less height of the discs even throughout the day. If you measure your height in the morning and in the evening, it will be different because of dehydration of your discs, even during the day. So with aging, which is prominent between age of 40–60, the range of movement of the disc will decrease, and the disc will flatten, and the mobility will reduce. So this is what's happening with the disc when it gets older. It becomes like an old flat tire. A decreasing of the water of the nucleus pulposus is leading to loss of tension of the annulus fibrosus, with all the instability and unphysiological loads, and that gives cumulative damage of the annulus fibrosus, and finally herniation of the nucleus and problems for your patients. And this will happen with the human being. When it gets old, the discs are getting smaller and drier, and that will change the posture of the body, and also will change the anatomical dimensions of the spinal canal. You can see that the disc space is narrow, the intervertebral foramen is narrow, and that causes problems like radicular compression, like compression of the coda equina sometimes, and some of these patients will end up being operated. This is important diagram. This is basically what is presented on the left-hand side. Is the top of the canal is removed. You can see that the cut goes through the pedicles and everything is unroofed. And you can see This is, for example, L4, L5 level on the left-hand side. And you can see the dimensions and the relations between the nerve roots and between the disc. So you have to be possible to tell me which is the exiting nerve root, and that's the exiting nerve root here at that level at L4, L5. And you have to be possible to tell me which is the traversing nerve root, and the traversing root is this one. That's the nerve root that starts at that level, but goes out on the level below. So this is very specific and very important for disc pathology, which is very common. This is why if you have, for example, L4, L5 disc, the most of the patients will be affected by L5 radiculopathy, because the disc that will be herniated will be irritating the traversing nerve root, but not the exiting nerve root. Exiting nerve root is affected only in a small percent of the cases. Let's say a few words about the sacrum. It's a curved triangular shaped bony structure that is basically constituted of 5 fused vertebrae in most of the cases. It provides stabilization and also communication with the pelvic girdle. Sometimes you may have anatomical variations, and let's say the sacrum could be 4, but not 5 vertebrae. And then if you see a well-shaped disc between S1 and S2, then you're talking about a lumbalization of the first sacral vertebra, and like that, S1 will become 6th lumbar vertebra. And then you can have the other process as well. The last lumbar vertebra can be associated with the sacrum. And in that case, you will talk about sacralization of the last lumbar vertebra. So these are anatomical variations which are actually quite common, and you have to know it. As I mentioned before, the sacrum is communicating with the pelvic girdle, and that is happening with the sacroiliac joints. A few words about the sacroiliac joints, very important because they are strong and weight-bearing synovial joints. They are covered by 2 different kinds of cartilage, and their function is to shock absorb, to allow the transverse rotations and to transmit the forces towards the pelvic girdle, and from there towards the hips. Motion that is allowed is anterior, posterior, sacral flexion, and sacral extension. This is obviously minimal motion, and after 40 becomes even less possible. But that's the age when your patients will have problems with the sacroiliac joint, especially after surgical procedures in the lumbar region. Just a few pictures to demonstrate a very typical approach in the lumbar spine. This is most of the operations in the lumbar spine will be done with this approach, obviously tailored with the specificity of the operation. First layer is the skin, and then the subcuticular layers, and then the fascia. You can see here we are cutting the fascia, and after we cut the fascia, then we detach the muscles, and we skeletonize the spinal process and the laminas. And then the last stage is this. You can see that the spinous process and the lamina of each vertebra, obviously the vertebrae that you need, is exposed. And then you can do different procedures. There is alternative approaches which are now being developed in terms of minimal invasive approaches, which will implement a smaller disturbance of the muscles, and this will be better for the recovery of your patient, but this is out of scope of this talk now. This slide is demonstrating different approach. This is the classical approach, minimal invasive approach that can give you one and the same result. And that was it from.
I'm sorry. Yeah, you're right on time. I was just about to say your time is up.
I know when to stop. Okay, let me unshare now.
Thank you very much, Mr. Pear, for that lovely talk. I'm sure that was very enjoyable for the medical students and everybody else. The next talk is on the future of spinal cord injury by Professor Salman Sharif. He is the chairman of the World Federation of Neurosurgical Societies Spine Committee and the president of the World Spinal Column Society and the chief of neurosurgery at Liachen National Hospital.
Okay, guys, it's really my pleasure. Can you hear me okay? And can you see okay?
Yes, sir, we can see you.
Okay, brilliant. I'm grateful for everybody who's chipped in for this conference. All the 50 representatives worldwide, people who are working from here, Imad, who's my secretary, and all the residents who chipped in. I'm grateful, and Sidra, who worked so hard for it. The whole idea is that we guys should know what neurosurgery is about and can ask questions directly. Anyway, so my topic today is recent advances in recovery after spinal cord injury. So spinal cord injury basically causes a loss of sensory motor function due to compromise of neural tissue integrity. So it could be in the form of a break, it could be in the form of discontinuation, accidents, falls, sports injuries, diseases, and depending on the severity and location, that could be incomplete and complete, and could involve upper limb and lower limb. So for example, if it's a mid-cervical injury, you can have all 4 limbs involved, but if it's lower thoracic injury, only lower limbs would be involved. And if you interrupt the spinal pathway below the lesions after spinal cord compromises, the body's ability to execute and coordinate movements is affected. Despite the disruption between brain and spinal cord, the brain can still generate appropriate motor commands. Treatments that are available, thinking about this concept, they're able to bypass cortical commands over the lesion site to appropriate descending motor pathways. So for example, if you have a lesion here, you could bypass with whatever means that you have available and go on to distally. Neuroprosthesis using a brain-machine interface aims to build such a bypass to electronically route this information in real time. Recent experiments show proof of concept of these bypass by using brain intention to directly stimulate the limb or spinal cord to reanimate or mimic motor function. So brain-machine interface is integration of brain-machine together to neuroprosthesis, providing an innovative approach to aid patients with sensory motor deficits. For example, it could go on to an artificial limb or leg, depending on what the problem is. So you could have multi-channel neural signals that could be transferred from the brain itself, and then they're translated into neuronal activity to execute commands. So for example, a robotic hand could be used with the help of brain understanding what is happening. So similar kind of thing, you could have it for a prosthetic arm, you could have it for wheelchair, you could have for your own leg as well if it's there. So I think there are various ways of doing this, and this is all practical now. So this neuromodulation of lumbosacral spinal network enabled independent stepping after complete paraplegia. So this is spinal cord stimulation to bypass the affected segment, which helps in patients to walk again with intensive training for 43 weeks. So patients were able to walk on treadmill, independent of assistance and body weight support system. So if we see that we have this session 33 here after 16 weeks, and we have session 43 after looking at session 111 after 43 weeks, and you can see that basically our amplitude that's coming out and the function that's coming out, how many steps they were able to take, keeps on increasing and how they're going. So all that activity in the muscle initially required a lot of help from 2-3 people. Later on, the person is only holding the patient only from the back and not much. And then the study from Giorgio Cortine from Lausanne demonstrated how epidural stimulation can help paraplegia to walk again. This follows the same procedure, first assisted walking, then patients starting to walk on their own. So for example, if we look at this video, so this is from Lausanne. So basically a spinal cord stimulator goes in and bridges the injury pathway. So it allows patients to regain voluntary control. And they need to put in a lot of effort with a lot of physiotherapists, a lot of stimulation. And they're able to lock their knees to start with. And then stimulator electrode recognize compromised brain impulse, which can't pass through the injured area, so causing paralysis. So this stimulates and causes that particular flexion and extension to work simultaneously. And the implant amplifies the signal, so it's strong enough to induce movements. So patients start the mapping process to find the best possible response. And first results of stimulation can be seen in first few days. And these people now with the stimulator able to move, and after that without the stimulator able to move. Let me move forward. And so you have got a stimulator, something like that, that we use also for pain and for spasticity and other reasons as well. So what you have is we take the brain, and we know there's some disruption here, this kind of injury is here. So we go on to the motor intention, swing and propulsion. So flexion and extension, we give a positive and negative response there. We decode these residual kinematics, and then implant pulse generator, and then that goes through into the electrode array, into the spinal cord, and then it stimulates. Once it stimulates, then you have the same chronology that we put them in a harness, a multi-directional gravity assistance walk, and we get them to stimulate inflection and extension, and we monitor all that. And so let's have a look what happens when we do all this in these patients in Walk Again project. So chronic paraplegia, this is even after 10 years of injury. So it's not acute injury that we are talking about. So somebody initially takes this much time. When we stimulate flexion and extension, so he imagines that I'm moving right and left leg, and the thing starts to move. So 8 muscles contract at the time they move. And this carries on, so it goes on very slowly. And then you compare the same training system. The patient was AISB. And you compare the first session and the 9th session. So you can see the speed with which they're able to move with flexion and extension coordination just by thinking in their brain that they are moving their legs. So, and if you look in 3D kinetics, same thing, how they're able to put their leg forward, just flexion and extension. So all those coordinators are working. So this is what's been happening lately, and people are moving forward with it. So the current treatment strategies for spinal cord injuries, non-pharmacological, we talked about decompression, stabilization, rehabilitation, CSF drainage. Then there is pharmacological therapy. Riluzole, Michael Feeling talked about it. There are other medicines that are underway, then cell transplant and scaffolding therapy that Michael Feeling talked about. So pharmacological treatment, Michael has gone into detail about this. I'm not going to go into that. Methylprednisolone, it's important to remember, is not recommended for spinal cord injury because of its risks that are involved with it. A stem cell, Michael has already talked about. So once you have put in an epidural or a brain machine interface stimulator, so what you do is you put the patient in this robot, and the robot lets you move. So because when you think, your right hand or left hand moves, when you think, when your right leg and left leg moves. So if electrode implanted in the brain and the signals are generated in mind for movement, these signals are decoded and translated via the robot arm. So you may not have any power, but you would be able to move. So with this exercise, day in, day out, work very hard with it, you're able to walk again. So we wrote this article a couple of years ago in World Neurosurgery, and the conclusion was that time may come when all patients with severe spinal cord injury are told, you will walk again. So I thank you all from Karachi, and hope you have a great time in this meeting and afterwards.
Thank you, sir. Such a nice talk. So, as we all have learned about the spinal cord injury, its evolution and future, it's time to learn about the future of degenerative spine disease. So, we would like to invite Professor Mehmet Zilali, who is Professor of Neurosurgery at University and past co-chairman WFNS Spine Committee, to share his knowledge and expertise with us.
Thank you, really. It's my great honor to be with you, all friends, and also many medical students and junior surgeons. I'm sharing my screen. My talk will be dealing with future of degenerative spine surgery. Is it on the screen now?
Yes, sir, it is on the screen.
Yeah, okay, thank you. There are many facts that we must tell here about the degeneration of spine. This should be considered as a natural process of aging. It mostly causes significant reduction in life quality, especially in the elderly, and the main symptom is pain. Sometimes back pain, sometimes leg pain, then deformity, then neurologic deficits. Actually, neurologic deficits is not very often. Surgery is not the sole or primary solution. There are many conservative measures: physical therapy, rehabilitation, manipulation, injections, external supports, etc. And what's new in the last 10 years in degenerative spine surgery? I will probably stress only some points, not all of them, but I divided in 5 sessions. One is the sacroiliac joint, the importance of sacroiliac joint. Actually, we learned that almost 25% of all low back pain is considered because of sacroiliac joint pain. So there are many options to treat this, and injections of steroids, making radiofrequency lesions, or fusion surgery even, which is not justified by many on one side of the sacroiliac joint. Another improvement is the MIS techniques. They became more popular, especially in the recent years. There are technical types can be divided into image-guided percutaneous, endoscopic, and mini-open surgeries. And you can apply MIS decompressions or discectomies, and MIS fusions or MIS deformity corrections. A very common disease, especially in the older ages, spinal stenosis, can be approached with a unilateral from unilateral side, and bilateral decompression may be done by preserving interspinous ligament and supraspinous ligament, and even the lamina. And you can even make one incision only, but approach 2 levels with one surgery. You can either use endoscope or microscope. There is one surgery for posterior cervical foraminotomy, which was done with that tube-guided surgery. There are also interlaminar endoscopy, which was developed in 2000s using water irrigation systems. And then we can compare interlaminar and transfemoral endoscopy, which is transfemoral is difficult for L5S1. Interlaminar is easier for L5S1. Another technique, transcutaneous approach, which was first implemented by Dr. Pimenta in 2003, has gained again popularity. There are many indications, and you can even with this minimally invasive technique, you can even correct some deformities. But there are lumbosacral plexus which may be injured, and expensive implants or setup are necessary. So somebody has now preferring OLIF, oblique lateral interbody fusion, instead of XLIF. Infection rates after a minimally invasive surgeries, according to this publication, is 10 times less than open surgery. But there are some disadvantages of MIS surgeries, like long-term results are very similar and more radiation to surgeon and the surgical team. And another fact is that the patients demand control our techniques instead of surgeons prefer it. What about the mobility preservation surgery? Actually, there are many types of mobility preservations, but some of them has disappeared by the time. And the main critic is that class 1 studies are always done by users of those implants and implant companies shadowing the results. This is the current condition. Total disc prosthesis, especially in cervical spine, and posterior dynamic fixations in lumbar spine are very popular. But these are experimental things: annulus replacement and repair, nucleus regeneration and repair. Some of them have been disappeared, as I mentioned before. One of them is the prosthetic disc nucleus, PDN, and they were moving inside this space. The total facet arthroplasty or TAP system has also been disappeared. Lumbar artificial disc has lost its popularity, and cervical arthroplasty has increased popularity. There are critics for arthroplasty. MR artifacts is one of them. Patient selection criteria are not very clear. Revisions are hard to manage. The main advantage of having a cervical disc arthroplasty is just decreasing the adjacent level disease. However, even with those arthroplastic cases, yearly incidence of adjacent level disease is about 3.1%. This is a large number. And this study from 2011 has shown that cervical disc arthroplasty group has 8.8%. However, so-called ACDF group has 10% adjacent level disease. And radiographic adjacent level disease is very common. However, symptomatic adjacent level degeneration is not that much. And they must have more limited indications. And if the main issue is adjacent level disease, after ACDF, it is 6.3%. Minimally invasive surgeries without fusion or artificial disc may be a solution. These are some critics. What about geriatric spine surgery? Populations are living longer, and aged patients have more instability and deformity. So then we have complex lumbar spinal stenosis. We are having more stabilization surgeries for elderly. At the age of 30 to 40, we are seeing many disc herniations. However, 50 to 60 years, we are having more spinal stenosis. So the first intention is to make decompressions, then after certain years, stabilization, and even later on, deformity correction. Aging is being kyphotic. Actually, this is a normal, natural sequence of life. Shall we correct it? And shall we correct all deformities? Yes, we can revert it, so that we can cause very good standing people in the old ages, but a good patient selection and surgical planning is very necessary. There are many complications of them, like you see here, upper level and lower level screw loosening and non-union. Long fixations in the elderly has got up to 50% complication rate. and 1 out of 3 patients are getting a reoperation. The problems of them are the weakened bones, osteoporosis, more deformities, and more premorbid diseases. We also learned sagittal and coronal balance, importance of that. This is quite new, and there are key points to measure that, and even for cervical spine. So then we need we need whole spine films to see if the patient has a good sagittal balance. Sagittal balance is important. Even in short fixations, there is a harmony between different spinal levels to create a balance. Even craniocervical junction contributes to that harmony. What about the future expectations? Pain sources will be better understood, probably. Using MIS techniques will lessen our complications. Mobility preservation surgeries will be evolved. Geriatric spine surgery criteria will better established, and certain geriatric deformities will be corrected with less morbidity. However, we have also negative expectations for future. Since we are looking at the images more instead of examining the patients, pain evaluation will not be done properly. Since no correlation between pain source and radiology, this will cause unnecessary treatments and surgeries. Unnecessary implants will increase by the effect of industry. Elevated costs will cause economical burdens, and longer training periods, especially for MIS surgeries, will be necessary, so that we will not teach people how to make good surgeries. Thank you for listening to me.
Thank you very much, Professor Zalali, for that lovely talk. Now we will invite Dr. Tiani Niu, Assistant Professor of the Department of Neurosurgery from Brown, USA, to present the evolution in spine tumor surgery.
Hey guys, I'm trying to share my screen. Just have a little bit technical difficulty. Let's see if it's working. Okay.
Hey, Mark, can you help? Can you make Tiani the co-host?
Yes, sir, he is already the host.
Yeah, I'm trying to share my screen and it is, hold on, let me see.
I have your presentation. Can I share?
Yes, go ahead, please. Oh, there we go. Thank you for sharing, Iman. Can everyone see the screen?
Yep, thank you.
Perfect. Iman, since you have the control, may I ask you to advance the slide as we go forward?
Yes, I have it.
Perfect, thank you. Thank you everyone for having me. Thank you for bearing with the technical difficulty. I will be giving a brief talk on evolution in spine tumor surgery today. Next slide, please. So over the past several decades, significant transformation has actually occurred in spine tumor treatment. Those are really centered on 3 categories of advances in the surgical technique, medical therapy, and radiation therapy. We'll talk about each one of them briefly today. Next slide, please. First, briefly, there are broadly 2 types of spine tumors, 2 large categories of spine tumors: metastases, which primary, metastatic spine tumors, meaning tumor comes from outside the spine itself. Most common origins being lung, breast, prostate, etc. Those are much more common. They account for approximately 90% of all spine tumors. And the goal of the surgery as of today is to remain palliative predominantly. Next slide, please. This is in contrast to primary spine tumor, which originate within the spine. Primary spine tumors can be divided into benign and malignant type. And the goal of the surgery, unlike the metastatic, is for cure or much longer term survival. Next slide, please. We'll first talk advances in surgical strategies. So for primary spine tumor, the predominant treatment modality remains surgical. In the 80s, Anakin sort of established and published treatment principles for long bone primary tumors in orthopedics. That idea and strategy was adopted to spine by Boreani and Weinstein and group, and they established this Weinstein-Boreani-Biagini sort of classification system, which is shown here. This system allows the surgeons to talk easily with each other in a sort of very accurate way, and also allow much more precise planning for a en-bloc resection of the Anakin appropriate en-bloc resection, remove the entire tumor with negative margin. It also increased safety as all the surrounding important structures around the spine is clearly delineated out. And the reason why this is important, we'll see in just a minute. Next slide, please. This is taken from the AO Spine Primary Tumor Registry. Now we have actually over 1,500 primary spine tumors, the most common one being chordoma. Next slide, please. So when we look at Anakin appropriate en-bloc resection, despite the risk with approach itself and the morbidity associated with the surgery itself, there's disease-free survival and it is significantly higher in patients who underwent Anakin appropriate en-bloc resection. And the local recurrence rate is also significantly lower, hence the benefit of performing Anakin appropriate resections. This has been shown in chordoma. And next slide, please. And also chondrosarcoma, and that's why surgery still remains a predominant treatment for primary spine tumors. Next slide, please. I'm going to change the gear slightly to the metastatic side. Many would argue actually the treatment strategy for metastatic spine tumors has had even more of a revolution than a primary tumor. Back in the 1990s, most surgeons would perform either a simple laminectomy or simple external beam radiation for metastatic spine tumors with spinal compression. Multiple studies have looked at the outcome, both in the neurological and pain. Next slide, please. And really, there's no significant difference between patients who underwent laminectomy with or without radiotherapy. And that has led to many wonder whether laminectomy was even necessary. Furthermore, patients who actually underwent laminectomy ended up suffering some delayed kyphosis and other morbidity associated with that. Next slide, please. This all changed in 2005 when this Petrol published this sort of landmark paper in Lancet, when he performed a randomized control trial, looked at a direct decompression plus radiation for treatment of spinal cord compression from metastatic spine tumor versus radiation alone. In this particular study, all radiosensitive tumors are excluded. It is a randomized control trial. Next slide, please. The outcome was surprising and very drastic. So this is one figure from the paper itself showing direct surgical circumferential decompression plus radiation has significantly longer duration of allow patients to remain ambulatory compared to radiation alone. Next slide, please. As a matter of fact, every single outcome is significantly better in the direct surgical decompression plus radiation group compared to radiation alone. This includes the ability to remain ambulatory, the duration of ambulatory status, the percentage of patients who actually regain ambulatory status, and even the pain control. Every single one of them is statistically significantly better in direct decompression plus radiation. Therefore, the lesson here is for patients with metastatic spine tumor with spinal cord compression, direct circumferential decompression plus radiation is superior to radiation alone. Next slide, please. Concurrent with the Petrol trial, radiation treatment has actually also been progressing as well. The SRS, the stereotactic radiosurgery, which was made popularized in intracranial work, has been adapted to the spine. And Peter Gersten and the group at Pittsburgh here, I think, looked at a large number of series with SRS treatment for the spine tumor mets. They actually had very encouraging results with very high 90% or so long-term pain control and 80% for radiographic local tumor control. What's more importantly here is some of the previously radio-resistant tumors, such as renal cell and melanoma, are now radiosensitive when you deliver large enough dose of radiation focusedly only to the tumor in the form of SRS. We'll talk more about that in a little bit when we specifically talk about radiation. Next slide, please. So currently, there are two really main indications to perform surgery for metastatic spine tumors. One being neurological decompression, as established by the Patrial trial, and the other being the instability. The instability criteria was really cemented in place by this paper from the Spine Oncology Study Group from Charles Fisher. Different factors affecting the stability of the spine, including location, the type of tumor, the effect of vertebral body, the posterior element involvement are all taken into consideration, and a scoring system is generated. This allows surgeons to easily identify whether a lesion is stable or unstable. And if it's unstable, obviously surgical stabilization will be indicated. Next slide, please. Putting all of this together, Ilya Laufer and Mark Bielski developed the NOMS framework, which include neurologic, oncologic, mechanical, and systemic factors. And you take all those factors into consideration, allow you to approach the patient with metastatic spine tumor individually and taking everything into consideration in a very comprehensive way. Next slide, please. We'll change the gear a little bit, talking about advancing surgical technology. So technological innovations have really, from both the industry and academia, and really allowed a lot of the incorporation of surgical technologies and techniques in taking care of patients with spine tumors. The general trajectory here is less invasive surgery, more accurate surgery, more durable construct, and easier placement of the construct. I'll show a few examples of those things. This is a patient of ours that we performed a multi-level hemicorpectomy for resection of this large cervical thoracic chordoma and the very classic posterior screw and rod construct for stabilization. Next slide, please. This is a different patient with a large focal lumbar chordoma. This is his preoperative MRI. The tumor is demarcated in red. Next slide, please. What we have been doing is we have been fusing the preoperative MRI with intraoperative CT scan from the patient. Here showing in orange is the fused tumor. This is from the same patient on the last slide. By fusing those together, it allows a very accurate intraoperative real-time idea of where the tumor is. This allows us to resect this entire tumor en bloc in an anakin-appropriate fashion while sacrificing the least amount of normal tissue. Next slide, please. Another technology that we have been using here, this is the same patient as last image with a large thoracolumbar chordoma here. We've been using patient-specific 3D printed models. On the very left, the model of the patient in the lateral view with the tumor, post-operative reconstruction, and AP view. We use this in the operating room itself, allow us to rotate a model, actually get a real live 3D look and with all the important surrounding structures. And all the way to the right, the reconstruction with the expandable cage anteriorly and the rod and screw construct posteriorly. Next slide, please. This is again another example of the patient-specific 3D modeling. Here, a patient with a craniocervical large schwannoma. Tumor is in green. It's showing the contact or the relationship between the carotid artery anteriorly, the vertebral artery within the tumor itself encased, and the surrounding important structure as the greater occipital nerves encased in it as well. Next slide, please. This is the 3D model from the first cervical thoracic junction chordoma patient. Again, the tumor is in green. Here you see and able to appreciate very clearly the relationship between the major vessel, the tumor, the ribs. The lungs are not pictured here, but they're further down, and the trachea and esophagus medially. 3D models can be rotated and held up by the personnel in the operating room and allow us to see live sort of surrounding important structures. Next slide, please. And one more example, again, the same thing. This is a young girl with a Ewing sarcoma involving the SI joint, and the 3D model, patient-specific model, the intraoperative specimen resected in an en-bloc fashion. The intraoperative post-resection CT scan with 3D reconstruction showing the defect, and the reconstruction with rod screw construct. Here, there's also the transilium bar going across. Next slide, please. This slide shows sort of advancement in the corpectomy or anterior column reconstruction technology. All the way to the left is one of the older mesh cage, static cage that was used more frequently before. In the middle, there's an expandable cage for a metastatic tumor patient, and then another, obviously much longer expandable cage for a primary tumor patient in the lumbar sacral junction. Next slide, please. The expandable cages are much easier to use as they can be inserted in a much shorter fashion and expand and occupy the space. As mentioned earlier, surgeries are moving towards more minimally invasive. This is the intraoperative picture showing a percutaneous screw placement with the X-ray and multiple level with the screws, and a resection of the tumor and a cage placement all through a tubular retractor. So minimally invasive surgery, smaller incision, allow people to recover sooner and get radiation or systemic chemotherapy sooner. Next slide, please. This slide illustrates the other sort of minimally invasive technique that we've been using is the incorporation of the methyl methacrylate bone cement. The bone cement can be used to augment the screw, which increase the pull-out strength of the screw, and therefore allows sometimes get away with a much smaller construct. It can also be used to reconstruct the anterior column. This patient on the left had metastatic lung cancer. Partial corpectomy was performed to achieve the separation surgery, free up the spinal cord for radiation. Anterior column was reconstructed with the cement, allowed instantaneous anterior column support, and very easy sort of minimally invasive placement way. To the right is a patient with multiple myeloma who had kyphoplasty with the cement, allowing the anterior column support and help with pathological fracture pain. Next slide, please. As discussed earlier, radiation therapy has had significant progress over the period as well. To the right, you're seeing three pictures of three different technologies. On the very top is a CyberKnife setup. CyberKnife is the very first complex SRS that's sort of being used directly for the spine SRS treatment. To the left is a final treatment plan for a patient with metastatic disease to the high cervical spine. Here you see the target to receiving 24 gray in a single fraction, with significant drop in radiation exposure to the spinal cord less than 10 gray, all single shot stereotactically straight to the tumor itself. SRS has been used for both metastatic and primary tumors. It's very effective for metastatic tumors, as discussed earlier, approximately 90% for pain control, 80% for local tumor control. For primary tumor, the results are really rather mixed. For primary tumor, really the radiation therapy options are the two images below. In the middle is proton beam therapy. Proton beam therapy is similar to a stereotactic radiosurgery, except the energy that's delivered is much higher, and there's a sharper drop in the radiation exposure to the surrounding structures. Therefore, it's more effective theoretically in the treatment of the primary spine tumors. There has been some study for surgically unresectable chordoma. The proton beam can achieve approximately 80% local tumor control. The very bottom picture is the newest here. It's carbon ion therapy. Carbon ion is same thing as proton beam, but a heavier ion. And carbon is heavier than the proton. Therefore, it delivers even more energy to the tumor, and in theory, should allow better tumor control. Next slide, please. Finally, we'll talk briefly about advancing medical therapy, which is really centered on development of immunotherapy. Here are some of the common immunotherapy targets and their corresponding tumors: BRAF, PD-1, PD-L1, CTLA-1, a lot of melanoma, non-small cell, and also renal cell carcinoma. Next slide, please. The important impacts here for surgeons are that cancer immunotherapy really have altered or altering how we actually do the prognosis for patients with metastatic spine diseases. They live longer now with immunotherapy that's more effective. Therefore, the established scoring system, such as Tomita, Tokuhashi, should really be viewed a little bit more skeptically because a lot of those patients are living longer and longer. More importantly, also for us, is surgical constructs durability. Spinal alignment should come into play as your patient live much longer than they previously did. Next slide, please.
Your time is nearly up.
Yeah.
You'll have to finish.
Yes, and put all together, spine tumors surgeries have evolved significantly over the last several decades. The advancing surgical, medical, and radiotherapy works synchronously together to improve the survival and outcome for the patients. And if anything, past several decades offer any lessons, the field will continue to progress in the future. Thank you.
Thank you, Dr. Tiano. That was a very insightful talk for all of us here. I would like to again invite Dr. Sadak Khan to moderate the question and answer session.
So a great session. One of the students asked Professor Nicolai that how can you prevent a lumbar disc? So how prevention for lumbar disc? Is he with us?
Nicolai, are you there? Maybe Mehmet can answer this question.
Sorry, can you repeat the question, please?
So how do you prevent a lumbar disc herniation?
Lumbar disc herniation, yeah. It's not possible every time, first of all, because it's like a degeneration. It's like your body parts are getting older or getting weird. But by decreasing the too much loads on your spine, you can prevent it partially. What are those? Actually, you must weight loss. You must not bend forward in the daily life. You must not be sitting all the time in a chair. You must be doing exercises to strengthen your muscles, and you must not smoke. Smoking is also causing or facilitating degeneration.
So what does the cat do, Mehmet? Is cat good for your long-lasting?
Yes, I am with the cat. They can't leave me.
So there are a couple of questions from the man of the art of Salman Sharif that he talked about stimulation and technology related to that. So when will that technology be available in low middle income countries, especially Pakistan?
As I said before, that this is experimental at the moment. The number of people that have been applied is less than 100 all over the world, and there are a couple of people from our region, as well from Pakistan as well, who have had this. Nearly all of them are walking with the help of the aid. When they switch on, they have a controller on their watch. So if they switch on their watch, and they're able to walk because it stimulates. At the same time, there are some who are walking without it as well. But this is over a long period of rehabilitation for pre and post insertion of these implants. So it's going to happen, but at the moment it's so expensive because the rehabilitation itself is unbelievably expensive. The implant, etc., is reasonable, but I think the whole thing together at the moment is out of our hand at the moment. And I think it's going to happen, and just like any other thing that comes in, that in the next 5 years or so, we would have it at a rate that everybody could afford in all the countries. Even in first world countries, majority people can't afford, and the government itself or big organizations who are running these trials are doing this at the moment. So I think, yes, with time it's going to come.
So how many questions can we take? We have a lot of questions. Can we take a couple of more questions?
Yeah, a couple more, please.
A question to Dr. Tiani. So will gamma or cyberknife surgery will take over neuro-oncological surgeries? I think they're talking about both spine and possibly brain as well.
Yeah, I think that's a good question. I think from the spine perspective, I think the Petrol trial made it very clear if you have high grade epidural spinal cord compression, surgery has a role. We need to decompress the spinal cord itself so the adequate amount of radiation can be delivered. So I don't think it'll completely take away the role of surgery. But for tumor that's centered specifically only within the vertebral body, yes, I think stereotactic radiosurgery is very effective for local control and for pain control. So they're going to take some of that. I think what's more interesting for the field is actually the medical aspect, and that's probably true for both primary and metastatic disease. We're moving more and more towards sort of medication treatment for tumor, and that sort of makes sense if you think, particularly in metastatic tumor perspective, it's a systemic disease. It's not really a surgical sort of isolated disease. So that's where I think the future is heading. But radiation oncologists is really more working collaboration than sort of taking over the surgical treatment.
So last question before we move on this next session, to Professor Mehmet Zalili, how can we manage post-op discogenic back pain if the pain is very immense, if the pain is very severe? Professor Mehmet?
Yes, this is our routine actually. We give mostly IV opioid drugs after surgery. Actually, after approximately 12 hours, 24 hours, that pain, early postoperative pain diminished substantially. But there are some other measures, like you can place an epidural catheter during surgery, and then you can give epidural opioids and epidural anesthetics for a while. Another thing is applying minimally invasive surgery instead of open large surgeries. Too much muscle dissection, too much skin incision may cause more pain. So then MIS surgeries diminish postoperative pain also.
So thank you, Dr. Saad, for moderating the session. Thank you, Dr. Mehmet. Our next speaker is the consultant neurosurgeon at the University of Virginia, Dr. Hassan Syed, who will be talking about artificial intelligence in neurosurgery.
Are you able to see my screen?
Yes, sir.
Okay, great. Again, my name is Hassan Syed. I'm really excited to be here in this conference to speak to you all, particularly about this subject, artificial intelligence in neurosurgery. I think there is a lot of innovation that is happening and ongoing, and particularly to the students who are interested in neurosurgery, I'm confident that you all will contribute in this aspect of neurosurgery as well. I also want to thank the organizers of the conference, particularly Dr. Salman, for the invitation and for pushing the field of neurosurgery, particularly in education, forward globally. It's very hard to talk 10 minutes about this subject, but I'm going to try to at least give a general overview of it. Essentially, I want to review the origins and concepts of artificial intelligence. I want to define the terminology associated with this field, and then discuss applications of AI in neurosurgery as well. So thinking about artificial intelligence, this is pervasive and ubiquitous within our everyday life. If you're using an iPhone, if you're ordering food via an app, just walking down the streets, your life is going to be affected by artificial intelligence, and we see this on a daily basis, both in our everyday life and within healthcare. And this is a diagram that sort of illustrates that AI in healthcare, especially in the US, there are many companies and startup companies that have formed within this space and are making an impact. And this really also gives us an idea of the intersection between medicine and technology and how that's going to be moved forward in the future as well. So the origins of AR are really from data science and the development of this as an institution in the field of study. And you can see here there are many words associated with data science, including artificial intelligence, machine learning, statistics, and oftentimes these terms can be confused. And I hope after this presentation you might be able to have a broader understanding of this as well. But this diagram really illustrates how these fields sort of intersect. You have data science at the center, but very important to that are statistics and scientific methods used in terms of pushing the field forward, including machine learning and algorithms, which I'll discuss in the future. But these new technologies and new innovations that we see in all aspects of our lives really stem from the concept of data science. And you can see that in articles that are published recently, whether it's from universities who are developing data science institutions, students who are joining data science programs, and leadership in institutions and in industry that are all tied to data science and artificial intelligence. Again, we'll be seeing more and more of this in our field in neurosurgery, as well as academics and the industry as well. And so artificial intelligence fundamentally is defined by this power of observation. It's something that we do on a daily basis within our field. And part of this is that pattern recognition that we utilize when we evaluate patients and also look at imaging studies and of course in surgery as well. And so artificial intelligence really just emphasizes the power of pattern recognition and tries to make things done in an efficient and streamlined fashion. So let's talk a little bit about the background of and the history of artificial intelligence. Now, John McCarthy, who is a computational and cognitive scientist, really is credited for coining the term in 1956. And during this time, he proposed a 2-month symposium where scholars in this field met at a research conference at Dartmouth. And these researchers were from international places, Harvard, MIT, IBM, Bell, so both from academics and from various companies. And this is where this concept really was born from. You also will hear about Alan Turing, who is widely considered the founder of theoretical computer science and also made significant progress within artificial intelligence. He was born in England and was part of the covert operations at Bletchley Park and part of the researchers that tried to decode the Nazi Enigma machine, the so-called Turing machine, in order to intercept communications and really helped in terms of the outcomes of the World War. So, fast forward, we have first works generally recognized as artificial intelligence by other notable personalities as well. So this is the Enigma machine itself, the cipher machine, and it allows for billions and billions of different types of encoded messages, and the parts included a keyboard, a lamp board, rotators, and a plug board. And because of all these different combinations, it was very difficult to decipher this machine. And with the research of Turing, he really made this complex machine that consisted approximately of 100 rotating drums. You can see on the right, 10 miles of wire and about 1 million of soldered connections. And so this machine searched through all the different possible combinations and helped to decode the letters into plain German and really understand the communications. So what is artificial intelligence and neurosurgery? This was an article published in 2021 that actually looked at the published literature, and you can see the dramatic rise in artificial intelligence when it comes to academic papers, particularly between 2017 and 2020 and currently as well. So there's a lot of interest in this, and this has to do with the technologies that have developed over time. So just to talk a little bit about the terminology and the relationship of AI, machine learning, and deep learning. Artificial intelligence aims to mimic the intelligent behavior of humans. Machine learning is a branch of AI and uses statistics and computer science to improve performance of the machines. And deep learning uses a multi-layered neural network to learn computation. And so in discussing AI, we must also understand what an algorithm is. And this is essentially a set of calculations that creates a model from data. How is that different from an AI-driven model? You can see that AI essentially emulates the human ability to come to a decision based on collected information. And this is a busy slide, but essentially the point I want to make is that machine learning is a branch of artificial intelligence that allows complex data sets to be analyzed without being explicitly programmed. And so there are different models and algorithms that are used, but for the sake of time, I'll continue on with the presentation. This is also important to note. Deep learning, essentially, it's a subset of machine learning that uses neural networks and multiple layers of algorithms to reiterate a task. And you can see an example of this in terms of machine learning versus deep learning when it comes to feature extraction. You can see in the top left, an input is such as a car, and whether or not it's classified as a car requires feature extraction and programming. For example, are there tires? Is there a rectangular structure for mirrors? Is there a hood, etc. Whereas deep learning essentially automates this process, where the actual program itself continues to learn as new input is inserted. So how is AI transforming healthcare? This concept of science fiction is becoming a reality. It's impacting diagnosis, prognosis, and management. And it really involves big data, computational power, advanced learning as well. The role of AI in neurosurgery, there are many different aspects that we think of, including helping with preoperative diagnosis, understanding intraoperative pathology, understanding surgical decision-making, and looking at complications and reducing adverse risks as well. Current applications within neurosurgery include spinal pathologies like lumbar stenosis and disc herniations, diagnosing brain tumors, epilepsy, trauma, and vascular pathology as well. And you can see this article that was published on the right in 2018 by the group at Mount Sinai, where they were able to automate diagnosis of various vascular pathologies on CT imaging. This slide sort of shows the workflow related to that, and you can see that the processing timing is considerably less with algorithms that are automated versus human interpretations. So much so that a CT that shows, for example, an intraparenchymal hemorrhage or a subdural hematoma can be notified to the doctor who's treating that patient in 3 minutes versus 12 minutes, depending on a standard workflow queue. AI is also seen in intraoperative pathology. You can see that this is an article that was published looking at Raman histology and various artificial intelligence mechanisms to diagnose almost instantly brain tumor specimens. And that can be helpful intraoperatively, whereas typical frozen sections take anywhere from 10 to 30 minutes, and that can alter surgical decision-making. How does this work? This is the general framework for an automated classification using a deep neural network. A sensory training set that's labeled is processed. Whole slides with unknown diagnoses are split into smaller fields, and this automated classification summates into a whole slide with the convolutional neural network to give a diagnosis. These are various articles in the literature in 2016, 17, and 2020, where this has been used in low-grade and high-grade tumors, more recently in skull-based tumors as well. And so certainly we'll see more of this in the future as well. I put this slide up for those interested in artificial intelligence and neurosurgery. These are some newer articles that have been published looking at the research, whether it's with predicting shunt failure, complications involved in neurosurgery, genomics and brain tumors. There is a lot out there and a lot of ways that we can contribute as well. Non-clinical uses of AI have also been present, especially in the era of high-touch technology and patients wanting to know their information. We have apps that are
your time is up. You'll have to finish.
Sure, no problem. I'll skip this just in terms of the work that we've been doing in terms of scoliosis evaluation. We'll have, I think, talks about robotics as well and how that contributes to artificial intelligence. And so there are a lot of challenges. The full impact has yet to be discovered, but this really is an exciting field that requires cross-collaboration amongst academics, researchers, industries, data scientists. And again, I'm very excited about the future and how we all will be participating in this. Thank you.
Thank you. Sir, as we all know that robots are taking over in all fields of life. So Dr. Mirza Poske will be discussing about the future of robotics in neurosurgery. He is a consultant neurosurgeon at the University Hospital Marburg, Germany, and active member of the WFNS Spine Committee.
Thank you. Can everybody see the presentation?
Yes, we can.
Okay. So, dear faculty members, dear colleagues, thank you for giving me this pleasure and opportunity to be a part of this great webinar. And I have my theme is future of robotics in neurosurgery. This is a pretty large theme, so I've tried to sum up everything which is current in the robotics in neurosurgery and the future possible applications of it. So, my name is Mirza Poeskic. I'm consultant neurosurgeon at Philips University Marburg in Germany, Department of Neurosurgery. This is where we are. And our chairman and professor is Christopher Nitzky, a famous name for medical technologies in neurosurgery, one of the people who introduced intraoperative MRI into the clinical practice back in the 90s. So we have a certain background when it comes to this. So robotics in my life came in 1991. This is the first surgical robot or the copy of a surgical robot which I had from the famous Star Wars series back then as a present from my father from a business trip to Germany. And 30 years later and 70 years later, after the first robots occurred, we didn't see a development which we hoped for in the robotics of neurosurgery. But when we look at the clinical application, it is going with a galloping step forward. So this is robotics in neurosurgery, the subjects which we are going to go briefly through. Between imagination and reality. So when we talk about robots, we always think that we will meet R2D2 or C3PO, one of the other robots which we know from the popular culture. But actually, the most which we got in the world right now are some robots which can, in form of chatbots, answer some simple questions to you, or this Curiosity rover, which can, with a human control, of course, stroll over Mars, but we still do not see the desired impact and the desired development in the field of surgery and in the field of neurosurgery. So to define a robot, this is any reprogrammable power manipulator with artificial sensing that can assist in a variety of surgical tasks. And the first application was in the neurosurgical field used for brain biopsies in 1980. Expansion of robotic surgery is limited by the delicate neurovascular structures in neurosurgical corridors. So this would be the first robot, the so-called father of all modern robots in the neurosurgery, a machine from the 80s, which was used the first brain biopsy with robotic support. Actually, a very simple robotic arm, but for that time, very high-end technique. Unfortunately, the technique from nowadays did not develop that much as we hoped in the last 40 years. These are some of the surgical robots which we can find on the market, and most of them are produced in high-tech countries such as the States, Western Europe, and newly China, Korea, and Japan. So we can classify robots as passive, semi-active devices and active devices, and systems which are able to perform fully automated procedures, and they are very rare, such as CT-based biopsy cutting, are called autonomous or supervisory controlled. With a human supervisor will be always close to robot but does not intervene. If the robot is entirely remotely controlled and the surgeon is in charge of every single motion of the robot, we then call it a teleoperated system. So this would be one supervisory controlled robotic system where robot executes the downloaded surgical plan. The robotic telesurgical system where the surgeon controls the robot in real time through the haptic interface. And the so-called shared control system, where robot and surgeon remain jointly in control of the procedure, while the robot provides steady hand manipulation of the instrument, and these are actually the most common robots nowadays. Application in neurosurgery is mostly for spine and stereotactic biopsies. Future applications are being examined in neurosurgical technological laboratories and in cadaver laboratories. Why do we need robotics? The tight anatomical confines that are armored by and oriented very specifically to bony structures, the highly technical nature of the field, the growth in minimally invasive neurosurgery, and culture that adopts and embraces new technology with optimism. Cobot surgeries. Most of the robots which we use today are cobots. They assist with a distinct but critical and sometimes difficult task of the operation. Anatomical localization, stabilization of the surgeon's hand during microsurgical work, or targeting of a pedicle skew. The inherent complexity of most operations is actually a big limiting factor. From the design, we have mechanical factors with rigid tools, which are most common in spine and endoscopy, and curved tools for transnasal approaches, biopsies, and endoscopic craniotomies. Compromise is to be found between balance between size and strength and the stress the tool is under. So, how to improve human-robot interactions? That is the main question in all the current research according robotic surgery, to increase the haptic feedback, to increase force sensing, for the surgeon to get a proprioception feedback, and the robot to transfer our process, to get the transfer of our proprioception to robotic arm, kinematics with motion amplification and filtering, integration of visualization and training with programmed virtual reality and preoperative virtual reality preparation, which is used to rehearse surgery. So stereotactic brain biopsies are actually procedures which are most commonly performed robotic, and they are state-of-the-art, becoming state-of-the-art. These are some recent papers on use of robots for stereotactic radiosurgery. These are the use of the stereotactic of the radiosurgery for of robotic guided surgery for epilepsy and for interstitial laser thermal therapy with MRI guidance, as you can see here, and used for the deep brain stimulation, where the literature shows reduction of operate time, reduction of human error, and increase of correct electrode placement. So the major use of robotics is when you need a very high accuracy of a placement of a certain implant. In cerebrovascular surgery, most of these robots are approved for cardiovascular and peripheral vascular interventions, but there were also coilings which were performed with these robots with the so-called CorePath GRX, where the advantages are precise device control, elimination of tremor, and radiation exposure reduction, and disadvantages are cost, duration of training, and this is very important, loss of tactile feedback, which is critical for performing fine motor tasks. In spine surgery, robots are currently used only for assisted pedicle screw placement, i.e. placement of K-wires, which is very important since the screw misplacement can occur up to 8.7% of the time in literature. And the first robot which was approved was Maser Spine Assist Renaissance in 2004. So now, almost 20 years later, we have a series of robots from all possible producers, which are being used for spine surgery. In spine, on the right side, you see the possible placement of a pedicle screw, and from the slide is clearly seen that the wrong placement of pedicle screw can have severe medical consequences for the patients, and that's why robots are getting into this market and getting into this surgery more and more. Robotics in spine surgery has a probe reduction of operative time, of wound surface and healing deficit, pedicle screw placement accuracy, decrease in revision and complication rates, and it's applicable with O-arm and intraoperative CT. And cons, well, probably the most important con is that it is the cost, longer operative time, registration and installation issues, and learning curve, which shows no improvement of surgical efficiency over time. These are some recent papers which show that the increased accuracy with the robot, especially compared to the standard X-ray or fluoroscopy and to ICT-guided navigation. And application of robots has shown that you can put a thicker pedicle screw with a maximally or perfect accuracy compared to other techniques. This is now an age of active robots for pedicle screw placement, where you have a robot which aligns automatically to the trajectory of the pedicle screw which you have already planned. So in standard passive robots, which are actually just holding instruments, you have to bring the robot to the trajectory you have planned. In the so-called active robots or robots with robotic alignment module or with that active trajectory, like the one we use at our department, the robot does that for yourself. These are some photos from our OR with intraoperative CT and with the use of the Circ Brain Labs robot, and one screenshot from the planning of the pedicle screws, where the surgery is then, or the alignment to the trajectory of the pedicle screw is executed by the robot. So robotic assistance allows for placement of screws with greater screw diameter and length compared with surgical navigation alone with similar accuracy. What robots in spine surgery cannot do, they cannot decompress, decorticate, or contour or place rods. However, I bring your attention to this recent paper where, although lacking FDA approval, this research group has used robotic-assisted trajectory to access Camping's triangle and percutaneous T-lift for iliac fixation metastatic cancer and sacroiliac fusions, and there are also some information on laparoscopic A-lift surgery. So, future of robotics would be that marketing and training trends push medical system towards the use of robotics. Since restriction of working hours is there, we have now less trained spine surgeons, which are expected to do more and more, and robotics could allow for increased safety. And currently, they act actually as guides to help position tool in an ideal position or trajectory. The future is bright since we have development of robotic suits in the OR, and safer and more thorough decompression have seen in experimental laboratories and cadavers, navigated automated osteotomies with deformity. Incorporation of artificial intelligence components facilitates partner operation, and MRI-based navigation could enable soft tissue handling. Robots are increasingly utilized for spinal tumor resection, radiofrequency ablations, osteotomy in deformity surgeries, and incorporation of the so-called Internet of Skills or Internet of Things and artificial intelligence, which utilizes low latency 5G connectivity, is enabling remote surgeries even if you are 1,500 to 3,000 kilometers away. Use of robots that are passive but provide no-fly zones around protected structures could enable robotic laminectomy. Gloves with motion sensors could allow for follower robots similar to the intuitive robot, which are capable of handling higher forces in spine surgery or more complex manipulation of tissue. And we could use robots for automatization of simple procedures, such as wound closure. Augmented reality and integration of augmented reality into robotics, as published several months ago in this systemic review, it enables decreased radiation exposure, enables fewer reoperations, enables more accuracy, and enables better intraoperative overview when combined with robotics. In these papers, the authors used a bed-mounted robot to possess 2 or more arms, which is each equipped with 2 to 3 joints and all the necessary tools to place a percutaneous screw and rod system. And one possible application is that AR headset could display 3D visualization of screw trajectories and pre- and intraoperative imaging scans individually. In skull-based surgery, this use in the daily practice is minimal, and this is an overview of research and studies which are mostly cadaver studies and revolve around endoscopic endonasal approach. Robotic guided spine skull-based surgery, this is an example from a newly published paper, which shows the transoral robotic guided surgery where the mucosal dissection is being performed at the console of the robot. There are several robotic systems which are used currently, especially for endoscopic endonasal surgery, but the clinical application is at the moment totally minimal. For neuroendoscopy, there are the so-called continuum robots, continuum or snake-like robots, which include concentric tube robots and tendon-driven robots, which avoid traditional long and rigid connections in fairer flexible curved segments. This is especially important in curvy regions like the ventricular system. And this is a model of this robot from the experimental studies in laboratories. And we see here that the first application of ventriculoscopy and of endoscopic function of ventricular cyst was actually from the year 2003. And almost 20 years later, robotic in neuroendoscopy has still not found its way, but the development of these techniques and making the robots more lighter, smaller, and easier to use will probably in the next 20 to 40 years make that application also possible. So in skull-based surgery, size and angulation capacity of the robot, lack of drilling components preventing fully robotic procedures and squats are limiting factor. And advantages are improved lighting and 3D visualization, replication of traditional gesture-based movements, and ability for dexterous movements ordinarily constrained by small operative corridors. This is one paper from the year 2015, which shows neurosurgical robot experimental design for deep and narrow spaces in the brains. These robots have usually several robotic arms, which are then combined and have these continuum or curved robots, which we talked about. Animal studies on use of robotic guided surgery in neuroendovascular interventions in surgery are currently ongoing. We were talking about the robot which is in use for peripheral vascular surgery, and the first robotic assisted coiling in Toronto was performed in year 2019.
Your time is nearly up. You'll have to conclude the presentation.
Okay. Nanotechnology, nanorobots are also expands a bit the scope of this lecture, because this is something which is actually coming in the next 30 to 40 years with nanorobotics. In microneurosurgery, the development of exoscopes and the initial experiences show that it is comparable to the use of microscope. And we have also robotic surgery for peripheral nerves, which is actually mostly in plastic surgery. Completely autonomous robots are actually something which is not going to happen very soon. Probably because every patient is universal and treatments are universal. But this is very interesting in University of Washington team, which is working on an autonomous robot conceptually called artificial intelligent neurosurgical robotic assistant, which will follow the surgeon and provide a certain basic assistance at the surgery. Artificial intelligence, we have also robots which are only helping the surgeons to eliminate tremor and fatigue, the so-called I-arms and R-Helis for surgical knee-rest. And actually the future, and I will conclude right now, is now, it's already happening. For example, in China, first ever 5G remote brain surgery for putting DBS in a patient which is 3,000 kilometers away. Famous laboratories at the Mayo Clinic and Duke, which are currently investigating robotic automated glioma and brain tumor resection using lasers. Bionat, which are using the so-called Bionats as a part of nanorobots to cross the blood-brain barrier. And the question which we are going to discuss later is, are the robots going to replace surgeon? Well, we have from 2000 22 from Johns Hopkins from January that robot performed first laparoscopic surgery without human help for the first time. And one could say never bet against innovation, never bet against technology. But on the other hand, if you see the resistance, which is in certain conservative parts of our profession and medicine in general, and the general public, these are only several very critical press releases about the robotic surgery. So I think we are moving somewhere between having robot as our enemy and having robot as our friend. Thank you for your attention, and sorry that I'm out of time a bit. Thank you.
Thank you, Dr. Poskic, and that was a beautiful talk, letting us know all that's happening in the robotic world. The next speaker is going to brief us on global neurosurgery. He is Dr. Saksham Gupta, Fellow of the Harvard School of Public Health, Boston, USA.
Can everybody see my slides okay?
Yeah, it's Dr. Gupta.
Okay, wonderful. Thank you all for being here. Thanks for the invitation to speak. My name's Saksham. I'm a neurosurgery trainee at the Brigham and Women's Hospital in Boston in the United States, and a global neurosurgery fellow at the Harvard School of Public Health right now, under the mentorship of Key Park. So I'll give a brief overview of global neurosurgery, including some of the research that's been done over the last 5-10 years, and some of our next aims kind of within our research group and more broadly. I'll give a very brief primer on global neurosurgery. I know everybody knows about it, but the definition of it has been changing a lot. It's now considered by most of us almost its own subspecialization. Like we think of tumor or vascular neurosurgery with a focus on improving access to safe, timely, and affordable neurosurgery for everybody, everywhere. This involves, some clinical subspecialization on some of the general neurosurgery that's done very commonly, and then a research focus, which involves things like epidemiology research and policy research and so on. There's been a evolution in what people consider global neurosurgery in the last 2 decades or so. It was dominated mostly by mission trips that were led by high-income country actors, which is the HIC abbreviation. And more recently, in the last 10-15 years, there's been a bigger push to not just do mission trips, but to better understand the problem through research, which has also been mostly led through high-income countries and public health programs. More recently, in the last 5-10 years, especially in our research group, the focus has been on, now that we understand the scale of the issues, to implement solutions, which cannot be done through high-income country actors, but are performed instead with partnerships between folks in low and middle-income countries and those in high-income countries, working together to implement solutions. I would say this right now is global neurosurgery 2.0, and I'll talk a little bit about global neurosurgery 3.0 towards the end of the talk. This all started with some of the research that was done. The field of global neurosurgery at large had to identify the problem at scale. So some of the research that was done 5-6 years ago demonstrated the problem of the fact that we don't have enough neurosurgeons in the world. There's only about 20%, so 1 in 5 countries that have 1 neurosurgeon for every 100,000 people. That's distributed unevenly throughout the world. You can see here the countries in green have more than 5 neurosurgeons per 100,000 people. And then those in orange and red have fewer than 5. These are mostly concentrated in Central, South Africa, North Africa, and the South and Southeast Asian regions and Pacific Islands. The flip side of this is that the neurosurgeons who are in some of these countries, these African countries and South and Southeast Asian countries, have a very unreasonable caseload that they need to try to get done, or including patients that don't end up even arriving to the hospital. So countries that you see here in yellow and red, again, in some of those same regions, have over 500 cases per neurosurgeon, which is a caseload that's nearly impossible to do. Some of the early focus on the research within, the epidemiology research within neurosurgery focused on some of the more common problems like traumatic brain injury and hydrocephalus. Some of our work at the program in global surgery at the School of Public Health here has focused on where the traumatic brain injury burden is. And all of us know that traumatic brain injuries happen often in urban areas, especially where there are areas that there are more cars and buses and motorcycles, but the helmet laws and road safety laws haven't kept up. So we found that the worldwide burden of traumatic brain injury tends to be highest in the Western Pacific region and Southeast Asian region. And this presents a double problem because in places that are developing still economically, traumatic brain injury treatment involves neurosurgery, but involves long rehabilitation. And rehabilitation centers, we're finding more and more, are less common in these places too. And secondarily, there's been a focus in global neurosurgery on hydrocephalus treatment and evaluation. A lot of infant hydrocephalus is preventable with folate supplementation, but in places where your diets are not supplemented by folate in things like rice or cereals, there can be an increased incidence of hydrocephalus that needs treatment. So we're finding that the global map of hydrocephalus tends to correspond with that folate supplementation, and a lot of the countries that don't have that quite yet instituted at the government level. Often these ones are in South America and Africa, tend to have a higher incidence of hydrocephalus. So that was kind of global neurosurgery 1.0. We needed to define the problem. The problem was a lot of traumatic brain injury and hydrocephalus, but a lot of other problems as well that I'll talk about soon too. The problem is that with this approach, with just the research, it doesn't really fix anything. So more recently, there's been a shift towards partnerships and collaborative program building. And one really great way that programs have been doing this are these bi-institutional partnerships with one high-income country actor that most commonly is in the United States, sometimes Canada and Europe as well, and then low and middle country income actors as well. Often, most of the collaborations are in Southeast Asia and Central Africa, but the goal being bilateral learning for both groups and bilateral support. So often, some planning support for surgical programs that are provided by high-income countries, and then teaching from both ends. Things like sending trainees from high-income countries to low-income countries to learn, and then sending trainees from lower-income countries to high-income countries to learn there as well, and understanding the different contexts. In the same study, we identified that most of these kind of partnerships, these dyads between high-income countries and lower-income countries, are occurring through either academic institutions or NGOs at high-income countries, and then almost exclusively at individual hospitals, usually associated with the university in low and middle-income countries. But critically, that leaves out something important, which is that to make a big change in global neurosurgery requires a big change in public health. That can't have neurosurgery can't happen alone without a good health system. And we found in this study that the partnerships between high-income country and lower middle-income country governments, so not just the academic institutions, hospitals, but the governments, were fairly low. And for that reason, we've moved even towards away from, or in addition to these bilateral partnerships, towards program building as well. So at our center, we focus a lot on these national surgical obstetrics and anesthesia plans. We call them NSOPs. And they're a way for interested low and middle income countries to kind of structure their surgical systems building. And that includes things like the people. So it makes sure that there's enough surgeons and trainees, the system, making sure there's good enough hospitals, and overall, other physicians as well that are important for surgery, like anesthesiologists and even primary care doctors and ICU doctors and nurses and so on, and stuff. So making sure they have the equipment that they need. How this has taken place is different in every country. We try to collaborate and work with countries that want to start this first. So it's a program that's driven by low and middle income country actors, that's supported by high income countries as well, but it needs to be driven by the LMICs first. And each country is a little bit different in how we implement it. This here is the NSOP for Pakistan. It was started the planning process for all this was started in 2018, and it's a plan that will go all the way up until 2025. But it's a excellent example of how each country is a little bit different. With Pakistan's NSOP, the country's too big and already has a very well-developed healthcare system, so it can't have, or the decision was made not to develop a national surgery plan, but instead develop multiple provincial surgery plans at each province level. So this is the kind of where the Pakistan planning is at, for an example of an NSOP. And so far, about 35 countries have developed these with us. And most importantly now, we're seeing that global neurosurgery is very hard to fund without integrating it into public health. There's a lot of global funding for things like malaria and women's health and so on, but we're trying to shift the paradigm away from funding individual diseases and individual topics to funding entire health systems. You can't have a strong neurosurgery system without a strong ICU and without good primary care and so on, and rehabilitation services. So we one of our next waves of priorities is to figure out how to integrate in neurosurgery with global public health, and figuring out how to find commonalities in things like roadway safety and folate supplementation, operating room safety, and overall healthcare delivery systems. For example, a neuro-oncology service, a brain tumor service, functions optimally when there's also good oncologists and radiation oncologists and so on. Critically, this is not just something that happens in developing nations. Global neurosurgery happens everywhere. It happens in the US too. There's an estimation that almost 50,000 US deaths can be prevented with just people wearing their helmets and seatbelts when they drive and operate bikes. One of our studies found that healthcare insurance is a problem in America, and it's very expensive to get healthcare. And we found that patients who don't have private insurance, so they're either funded by our Medicaid system if they're poor, or have to pay out of pocket for their costs, are more likely to present to the hospital needing urgent surgery for meningioma, which is a benign disease that for patients with private insurance is most often just found in the clinic, and we can schedule it electively. But those who don't have the ability to pay for clinic appointments are often coming in through the ER for urgent operations. So global neurosurgery happens everywhere. And
I'm sorry, your time is nearly up. So
oh, perfect. Thank you. And then my last thing here is just that the next wave of global neurosurgery is now led by LMICs. It's building resilient systems. And there's some great papers from groups in Africa, Southeast Asia, including some of the folks on this call today, on some of the training and so on that's being done. I'll skip this. And yes, our next set of priorities, so our studies in the next 5 years, are to support LMIC-led initiatives, and update on the neurosurgery workforce, is to find out how many neurosurgeons there are, how many trainees there are, and to measure the impact of our surgical plans that we're making, now that we've had about 30 or so of them. And then finally, to finance neurosurgery, which is very expensive, and to figure out how to make it affordable for everybody. So thank you to everybody. Thank you to the WNSC committee for inviting us to give this talk.
Thank you, Dr. Gupta, for that lovely talk. Our next speaker is Professor Farida Amin. She's a director of the Indus College of Family Medicine and Public Health and interim chair, Indus Hospital Research Center, Pakistan. She'll be guiding us on research for beginners. Thank you.
Thank you very much. Is my presentation shared? Can you see the presentation?
Yep. Yes, Professor.
Yeah, so thank you. So I really enjoyed Dr. Gupta's talk, and it's heartening to see people are thinking about integrating public health and neurosurgery, and it is much needed, especially in a developing country like Pakistan. So I'm just going to keep my presentation at a very basic level, because I was told that there are quite a few medical students over here, and they would just like to know where to start their research from. So we would talk about basics of research and why do you need to do research and where to look for new research ideas. So research, as the name suggests, research, an organized inquiry carried out to provide information to solve problems, and it is the cornerstone of every science. So it works like, you come up with a hypothesis and you try to find evidence to prove it. From the results you get, you learn more, and hence, further ideas are generated, and the cycle goes on and on. So these are all the reasons you, as medical students, out of all these reasons, you may want to do research because you want to advance your career. If you want to get a spot in residency program after your graduation, research would give you an edge over other candidates. So this is just a basic classification of research, and I'm just going to talk about the practical implications of it. How whenever you're in a clinic or in a OT, where to find research ideas from. So that's what we are going to talk about in a practical situation. So, for example, just let's look at this case. While attending a clinic, you see multiple patients with unexplained backache who do not respond to standard therapies. The consultant asks you to search for neurotherapies that may help. And So you search books and recent literature and come across discovery of certain molecules known as nerve growth factors, which have a role in chronic backache. So, what comes to your mind? Could this be a new therapeutic target for chronic backache? And if there's a chemical which could inhibit the NGF, would back pain resolve, or back pain could get better with that new therapeutic agent? So how do you begin to answer these questions? So you look for basic research, which is just bench work, right? So you might want to start with lab work to look at the new NGF signaling pathways, or you might want to look at certain inhibitors of NGF, so that could be later translated to applied research, which is like you can carry out human trials with your supervisors, with your consultants, and you can look at the new molecule if that actually works at a human level as well. So that's applied research. And then you let's look at this case. You're working in a primary care community health clinic, and this is the 6th adolescent patient you saw in a week complaining of chronic backache. And this makes you wonder about the frequency of backache in this population, in this specific community, and you also think about the risk factors. So I'm sure you can think about so many risk factors which might lead to, backache among adolescents, but this is something which is a problem in a lot of parts of the world. I don't know if the developed countries suffer from the same issue or not, but we do. So you move on to do a descriptive research, which means that you would want to know the frequency of backache in that specific community, and analytical research, which would tell you what are the risk factors which are associated with back pain. So the question which might come to your mind or your study would be frequency and risk factors associated with chronic backache among adolescents in the specific community you're looking at. If you further want to, do an experiment or do an intervention, you can look at the effect of a certain intervention you do on the chronic backache among adolescents. If that reduces the frequency of, or if that intervention helps them in the long term. So this is a paper which was published in Journal of Pain Research. So somebody might have thought about it, starting from the frequency to the risk factors, and then finally doing an intervention to make a difference. So this is experimental research. And then there are certain methodological approaches which you might want to take up, such as quantitative approach or a qualitative approach, or you want to move to mixed methods, and you can use both the approaches at the same time. So when you're talking about a quantitative approach, that means that you're conducting a survey, or you're scoring. For example, you score pain, you score quality of life, or you ask certain questions, and you analyze those, objectively you analyze the data. When we're talking about qualitative research, you're talking about a subjective, you draw subjective conclusions. It might involve an interview or a focus group discussion. So you look at perspectives of the patients rather than, looking for objective data. For example, psychosocial consequences of hearing the word tumor from the doctor. So me being a family physician, I think that means a lot to me as to, how to convey bad news to the patient. So this is something, if I want to research, I would be looking for a qualitative study design rather than a quantitative study design. So with that, I'm just going to leave you with that curiosity and imagination roaming around. As research is formalized curiosity, it is poking and prying with a purpose. Thank you.
Thank you, Dr. Farida. Now, we would like to invite 3 best paper presenters shortlisted by the committee among all the submitters.
Sorry, we need to have discussion first before we do that. Discussion for these questions, this session.
Okay, sir. Dr. Saad, can you moderate, please?
So, is this the panel discussion, or do you
No,
need
no,
to
no.
continue?
No. Yeah, the last 4 talks need to be discussed.
There's a lot of questions around, and there's one for Dr. Hassan Syed. and he said the question is that his talk was more on prognosis. Uh, what about the operative accuracy?
Yeah, so thank you for that question. So yeah, absolutely. Just in general, artificial intelligence has many implications within neurosurgery. I spoke a little bit about diagnosis, but you know, I didn't speak about other aspects of it because the topic is very broad. You could spend you know, weeks talking about all the different implications. I know that other speakers did talk about robotics as well, but you have to understand that artificial intelligence, you know, has an implication in all these things. All these talks that we've had, these great talks, there are implications of artificial intelligence, and that just the basis of that is data. And the more data we get, the more we can understand how to do things safely for the patient, whether it has to do with diagnosis, prognosis, surgical accuracy. These are all potential applications within neurosurgery, and that's why it's such an exciting field. We're really have made progress, but we're at its infancy. There is a lot of things that there are a lot of things that will develop over time, and that's why it's an exciting area.
So the next question is with Dr. Pochkit. How do you make indication for a spine robotic surgery? How do you decide that you're going to do a spine surgery on this patient? Is there a specific indication?
Sorry, Mirza will be back in 10 minutes. He had to take a call. So maybe we can delay his questions for later.
So most of the questions, maybe we can go back to, yeah.
So any questions for research talk?
No, I don't think so. Not yet till yet. There's a lot of questions about robotic neurosurgery.
Okay, great. So and any questions for Hassan to follow?
So there was one question that how do you at this at the medical student level, how do you learn about artificial intelligence, you know, or machine learning or neural networks, you know, as a medical student, if somebody is interested in artificial intelligence?
Yeah, I think that's a great question. There are a lot of review articles and papers about this subject to get a general overview of it. Besides that, as I was talking about within the talk, it's really a cross collaboration among disciplines, and so it's also important to network with your mentors, you know, both in neurosurgery and in other disciplines as well. The reason we're making good progress in neurosurgery is we have to be able to talk to other disciplines as well and see how those ideas can apply within neurosurgery. And that has to do with artificial intelligence too, whether it's data science, whether it's computer scientists, other surgeons who've done similar things. So the best way is to try to get a general overview, an understanding of artificial intelligence, and then speak to colleagues within your own academic institutions or friends or family that you have, and these ideas sort of cross-pollinate.
So there's one question regarding global neurosurgery, that how do you consider global neurosurgery effort to be successful? What are the parameters, as often the first world country is not compatible to the third world?
I don't see
Dr.
section
Sasham.
here. I think he's left as well.
You know, so talking about artificial intelligence, if I may, that it is something that interests me as well. So we can talk about that, or you know, maybe we can discuss research with Dr. Farida, that you know, at a medical student level, how do you actually start with the research project? Do you find a mentor? Or do you come up with a topic yourself? I mean, what is her advice to medical students if they want to do research?
So research is, as I already said, it's an organized approach, right, to searching again. So it has to be the process should be organized as well. So you have to find a mentor, or you have to find a supervisor or a consultant you can work with. So you start at a very basic level, just start with collecting data, reading the protocols or reading the synopsis, which has been written by the whole group, whole team. And from there you can take up. You can also take up certain courses which can help you out through building up your protocol. So the research starts with planning. So you have to plan first. You have to come up with a protocol first. And to make a protocol, you need some help. For example, you have to learn how to come up with objectives and how to come up with a study design and how to come up with a questionnaire. So it needs a lot of training as well. So I think people who are interested in it, they should start from now.
So
shall we move on then? Thank you.
Yeah, I think, yeah.
So now we would like to invite the 3 best presenters shortlisted by the committee. Among all the submitted abstracts, each will be given 3 minutes for their abstract presentation. All the 3 presenters will be awarded with WSCS MIS book. So Dr. Minam Farooq from Pakistan will be presenting his abstract.
Thank you so much. Can I start? Am I audible?
Yes.
Okay. So I hope you all are doing final year medical. And for the past 2 years, I've been into research. And currently, I'm a research collaborator at Glasgow Neuro Society at the Einstein Health Philadelphia and also the MDR collab. So the research that we recently conducted was about the impact of ABO blood group in DCI and the clinical outcomes following the aneurysmal subarachnoid hemorrhage in a Pakistani cohort. Just a little introduction about it, that aneurysmal subarachnoid hemorrhage is a very severe condition in which the blood, basically due to an aneurysmal cause, collects in the subarachnoid space. And after the treatment of it, basically after the vascular clamping, there is a risk of delayed cerebral ischemia, which I'll be referring to as DCI, which causes about 25 to 50% of the mortality rate. Our study was also recently accepted in research British rheumatology. Yeah. So there are 2 factors, literature. So the blood groups have a few effects on DCI. First,
So Dr. Manam, there is some internet issue with us. We cannot hear you properly.
O blood group. Just towards back. Am I audible now? There is a general issue with internet in Pakistan these days because of the flood. So all kinds of it, whether it's mobile data or Wi-Fi. So I do apologize for that. And okay, so am I audible now? Should I continue?
Yeah, please come to your talk itself. Just move forward. Introduction, I think move forward. Otherwise, your 3 minutes are already up.
So my hypothesis was that how O blood group is going to be connected to the DCI. And our objective was in general to study all types of blood groups in relation to DCI in the Pakistani cohort. The methods were that we conducted a retrospective cohort study over the past 5 years from 2015 to 2020, in which about 175 patients that were diagnosed aneurysmal subarachnoid hemorrhage patients in Jinnah Hospital were included in the study, and then we used SPSS for data analysis. 18 years and above, all the patients that information or their etiology. So in addition to ABO blood group, we also had some other variables involved in our study. Variables like gender,
Apologies, Dr.
age,
Farooq.
BMI, and space, and then we also included
Your internet connection seems to be going up and down, and your time is up. Is there a way to get through the results and conclude?
Yes.
Please?
So our results showed that DCI basically, let me go to the main graph. So our results basically show that DCI, that the O blood group is directly related with the DCI. And that is why what we did was that we also included other confounders like BMI and modified Fisher grade. And then we ran a logistic regression, which finally proved statistically that O blood group is more prevalent in DCI patients. And O blood group has a more severity of having a greater severe DCI, and hence our clinical implications and the conclusion includes that the O blood group patients that undergo aneurysmal subarachnoid hemorrhage and DCI should be monitored closely. And also there should be other studies in other ethnicities too to really establish the relationship between which blood group is more connected with DCI and aneurysmal subarachnoid hemorrhage. So that's it.
Thank you, Mina. Dr. Kevin Divani, it's from India. It's your turn. Please start your talk.
Yeah, sure. Is my screen visible and am I audible?
Yes, you are audible.
Yeah, so good evening to everyone from India, and I'll be presenting my stem auditory evoked potential and Glasgow coma scale in head injury patients. Basically, we derived this idea by looking at anesthesiologists who use BIS monitoring, that is bispectral index monitoring, to monitor the depth of anesthesia. So that is how we derived this brainchild. And we intended to compare the outcome derived from brainstem auditory evoked potential with Glasgow coma scale. And we also intended to decide the efficacy of auditory evoked potential in head injury prognosis. So a cross-sectional study of 66 isolated head injury patients were performed. And this is what we derived our conclusions from. This is a ROC curve, which is a receiver operating characteristic curve, plotted for patients with Glasgow who are monitored with Glasgow coma scale and auditory evoked potential. As there are a lot of novices in the audience, I would keep the interpretation very simple. Basically, any test which is above the green line, which is plotted in the center of the graph, is considered as characteristic. And more the line or more the curve towards the top left corner, more is the reliability and specificity of that test. The area under curve for GCS ROC curve is 0.87, whereas for auditory evoked potential is 0.9. And the standard error is also less, which suggests that it is reproducible for larger populations. And the p-value for both the tests were significant, and the sensitivity of auditory evoked potential was much higher, as well as the positive predictive value. So as compared to GCS, auditory evoked potential is higher area under ROC curve and hence higher sensitivity in predicting prognosis in head injury patients. So I would like to conclude with saying that Glasgow coma scale, though is easy to apply and universally accepted, but is a subjective test, whereas auditory evoked potential is an objective test and it is much easier to interpret. Gross and auditory evoked potential is a relatively specific evaluation of brainstem function. It is unaffected by drugs, metabolic or toxic encephalopathy, which is not the case with Glasgow coma scale. Hence, both the tools considered here have a good discrimination ability to predict prognosis in head injury patients. However, brainstem auditory evoked potential, being an objective test, is unaffected by sedation with a higher sensitivity, emerges as a better predictor than GCS. Thank you.
Thank you, Dr. Kevin. Now, Dr. Manuel Encarn.
Yes, hello. Yes, I'm gonna share my. Yes, I'm gonna share my screen. Do you all, everybody can see my screen?
Not yet.
Okay, I am sharing my screen now. Yeah, now yes, right?
Yes.
Yes, first of all, thanks for the invitation. It's an honor and pleasure for me to be here. We're going to talk about the prospective comparative study of the low-cost exoscope. I'm going to try to make it very fast for the lack of time. My name is Manuel Encarnacion, and also my head of department, Renat Nurko-Metov, going to be with us. There is no any kind of conflict of interest. I'm going to be presenting some products, but there is not any business on this. First, this low-cost exoscope, this is not a microscope killer. This can be an adjuvant tool for the microscope in the low-income countries, or countries where there is not the possibilities to get a microscope. We have two ways. Here you can see the lack of a proper neurosurgery treatment in the low-income countries, or before called as third world. There is a lot of studies talking about, with good results, talking about the use of the exoscope in the neurosurgery. But also we need to know the limitation in the low-income countries. So the question is, this is a question somebody asked me before. Why I need to get the low-cost exoscope if I can get the microscope approximately in $15,000? But the question is, all the countries, low-income countries, have this $15,000 in the all the neurosurgery department? No, this is a reality. There is a lot of exoscope, very good quality in the market, but as I say before, it's not affordable for the low-income countries, because these tools can cost $20,000, $50,000, even $100,000, even more, even $250,000. As I show you here, you can see the cost of the analysis of the exoscope in the market. Okay. Now I present here the low-cost exoscope. Oh, sorry. This is the low-cost exoscope. It's a very simple tool. I can ask for all of you, the quality of the pictures don't gonna be like the Hubble, okay? Like the James Webb, sorry, like the James Webb. Don't expect this is gonna be James Webb pictures, okay? But this can be a proper tool for the low-income countries. So I'm gonna show you the pictures and the study we performed, and you will see how much the quality, how good are the quality, how much these tools cost, and the times of the installation. The time of the installation is the 1 to 5 minutes, even less than a microscope, as you can see here. We can even have an exoscope, Wi-Fi exoscope without connection. And I'm gonna ask you, how much you think this is the cost of this tool? First, let's see the picture. Yeah, let's get ready to rumble, and let's see the picture of, and later you're gonna tell me about the price. You can see here, this is a L5 in the root. This is in Misty Leaf here where it performs. You can see the quality of the picture of the low-cost exoscope. This is a low-cost exoscope, Wi-Fi, because as you can see here, we don't need any cable, any connection. Again, the low-cost exoscope. You can see the dural sac here. This is our head of department teaching, because this instrument is going to be very good for teaching. Here you can see an ACDF surgery. Again. Anybody can give me the idea of how much this can cost? It's an open question. Okay, I go ahead.
Sorry, Manuel, time is running out. You need to speed up.
Yeah,
you can tell us the cost.
Yes, the cost is $150. So you can see with $150, the surgeries we can perform. Of course, this kind of tools we don't need to use in some countries, in first world country or developed countries, because
Apologies,
they
Dr.
have
Manuel. Your time is up. If you're able to present the conclusion, please.
Yeah. This is the study we performed about the exoscope. This is here I showed you the limitation of the low-cost exoscope. the limitation, as you can see here. Then our conclusions. And in the end, something to get to you home is one day when we are not here, we will be what we have done. Thank you.
Thank you. Now I would like to invite Dr. Zarina Brady to talk on UK perspective. Dr. Zarina.
Hello, everyone. Firstly, just thank you so much for having me here, and thank you to all the presenters and to the medical students who have presented today. Everything has been wonderful and a pleasure to listen to and participate in. Firstly, can you see my screen perfect?
Yes, yeah, sure.
Wonderful, wonderful. So I'm a senior health officer. Currently, I am in Northern Ireland, in a very small place called Derry. And today I just wanted to quickly speak about the path really to becoming a neurosurgeon. If any of you are interested, or hopefully at the end of this talk, you might be interested to becoming a neurosurgeon in United Kingdom. So I will just discuss the pathway, the entrance exams that we have, some portfolio. I will quickly touch on portfolio, the core surgery training years 1 to 8, and then possibly some fellowships. So here is our rough timeline that we have. So applications opens in November, closes in December. Then we have a shortlisting of the candidates occurs in January. And you must take an exam called the MS or a exam multi-specialty recruitment examination, which will be in early January. Interviews will then be in March and followed by a shortlisting. So the shortlisting criteria covers about 13 points. It is very specialized, and I don't want to alarm any possible candidates that wish to go to United Kingdom. It's a wonderful country to train in, to be involved in research there, and of course to become a neurosurgeon there. But if you wish, start today, okay? If you get anything from my talk, start today with your career. And as previously was mentioned, you know, have a 5-year plan. When I was a medical student, had a 5-year plan, a 1-year plan. Every year have a plan, your goals, and set them. It helps you achieve them at a bigger picture when a specialty such as neurosurgery is so competitive. So in your early undergraduate career, you need to complete some research projects, quality improvement projects, or QI projects. So research can be anything from case-based discussions, quality improvement projects, as I mentioned, any original articles. You know, the higher the level you'll go up in. Some academic awards there after you graduate from medical school. These can be achieved by attending conferences, podium presentations, things like this. Publications, so publications must be on PubMed for them to be recognized and for you to get the points for them. Organizational skills and leadership skills. So these come into organizing conferences, organizing courses for other medical students, things like this. And then of course, teaching, you must always give back to your juniors, of course. So the MSRA exam, it is a 2-part exam. Really focuses on professional dilemmas and then clinical problem solving. Your question types will be, you'll need to rank the most important to the least appropriate. It will be a multiple choice question, which is based at a junior doctor level, and it will be computer based. Followed by, you will have an interview, a formal interview, which your CV and all of your portfolio will be judged. Understanding the specialty, again, as was mentioned multiple times today, is very important at the level of you want to become a neurosurgeon, and it's a difficult path to follow, but it's an enjoyable one, and it's one that you should make an informed decision in currently. So in United Kingdom currently, in England, we have 28 centres who you can train under. In Scotland, we have 4. In Wales, we have 1. And then of course, in Northern Ireland, where I practice, currently we have only also 1. So your journey as a neurosurgeon in the United Kingdom would be a 4-year period. Of course, if you are female and you're to take years out to have children, it would be longer. Your initial training are year 1 and 2, followed by a member of the Royal College of Surgeons fellowship examination, which you must complete. Then you will go into your higher training program and you'll finish with a final exit exam. So in years 1 to 2, you'll, like everything, all specialties, you will build on the basics and go upwards. So core neuroscience training will be in year 1, and initial neurosurgical training will be in year 2 to 3, followed by your membership of Royal College of Surgeons examination. Then you'll go into years 4, 5, 6, 7, which will be more specialized, and you'll have final training programs continued with your exit examination. So these are just a very, very small list of some subspecialties which you can be involved in. And I urge you, neurosurgery is a very big, vast field out there. I urge you there to just have a read around neurosurgery in general. It's a very big field, and you can get involved in many different types of projects. And then lastly, we have different societies and fellowship opportunities. So the fellowship opportunities would come later on in your career, but it's very good even at a junior level to just be aware of them, be aware of the societies, get involved. Many of them offer junior fellows and junior colleague, collaboration and research collaboration, or even, to help in your development in the specialty. So life as a neurosurgeon, you will be in all parts of the hospital. You will be collaborating with different subspecialties, different specialties as well. You will be in trauma calls. You'll be teaching other colleagues at the same level, perhaps, teaching other colleagues at a lower level, perhaps. You'll be communicating with all different people from different parts of life, which is a wonderful opportunity. And it's very rewarding. So there's always two sides to every story, So what's good about the life of a neurosurgeon? Well, it's very rewarding. You get to collaborate with many specialties, and you vastly improve the patient's quality of life. And you're really at the forefront of medical and surgical advancements. Now, as we have seen today, of course, what's bad about it? Well, the days aren't easy. The days are long, they're hard, you're tired. And training requires a lot of movement. Fellowships require a lot of movement, a lot of travel. So family life can be difficult. But in the end, it's a very rewarding specialty to be in and to be a part of. And it's really at the forefront of changing in society and changing medicine and improving patients' lives. So thank you very much.
Thank you, Zarina. Next in our panel discussion is on would artificial intelligence and robots by Professor Joachim Ertel from Germany, Professor Edward Penzel from Cleveland Clinic. He's also the founding president of World Spinal Column Society. Professor Einblock from South Africa and Dr. Mirza Poskek from Germany.
So right now I'm starting the video recorded by Dr. Ed Wenzel. Hello, glad to be here talking to all you young, eager medical students who have an interest in neurosurgery. Neurosurgery is a wonderful field, and I am sure that you will enjoy your career as it proceeds from this point on. The topic here is artificial intelligence and machine learning. I would start off by saying that I'm not an expert in this arena, but I do have opinions, and we have written a couple of papers regarding machine learning, but I most certainly do not have the faculties or in knowledge to truly understand the basics of machine learning, but I have a couple of opinions that I'd like to share with you about its utility. What it is not is magic. We still need to make decisions. We still need to manage patients in the best way we know how. What it can be is a tool, and it can tell us a couple of things by looking through and scanning patient information. It can tell us risk for surgery. For example, with deformity surgery, there is a very high complication rate, and that can in and of itself be a contraindication to surgery. And so being able to counsel the patient effectively with relatively solid information based on the learning that the machine has done over time can provide useful information for the patient and for the physician. What it can also do, though, which may be of greater importance, is tell us who not to operate on. One of the biggest problems we face around the world are chronic pain syndromes, and they can masquerade as legitimate problems such as mechanical back pain, etc. We should, in and of ourselves, be able to sort these out, but physicians don't seem to see what I call the elephant in the room, the patient with a chronic pain syndrome, and the fact that they have a very poor likelihood of benefiting from surgery. Simple questions that we could ask the patient may give us a high indication that their problem is chronic pain, not L4-5 spondylolisthesis requiring a fusion. And those are, do you have restful sleep, restorative sleep? Do you feel energized when you wake up in the morning? Are you fatigued throughout the day? Do you have pain in more than one parts of your body? In other words, multiple unrelated somatic complaints. Does the pain cause you a significant amount of suffering? And is your pain there 24/7? Pain that is present 24/7 can very likely not be managed by a surgical intervention. Now, we should be able to figure this out ourselves, but we often do not. And machine learning with appropriate health-related quality of life metrics and questions, such as the PROMISE modules, can help us tremendously in sorting out patients who might benefit from surgery and those most specifically who are not candidates for surgery because they have something else going on. So machine learning can help us. I don't think we should rely on it excessively, but it's a tool. And we should use tools that we have available to us. And it will, I am virtually certain, machine learning and artificial intelligence will increasingly play a role in the decision-making process for neurosurgery and in fact, for all of medicine. Thank you.
So we are going to have the discussion session with Dr. Mirza and Dr. Einblock.
Thank you very much. I'm not sure if I can maybe start off and maybe just put a bit of a marker out there for Mirza. Mirza is a very competent and spinal surgeon, very adept at robotic surgery, and has adopted in spinal surgery, has adopted the technology really embraced it. So I'm going to come a little bit from the other side, and I'm going to be a little bit more pessimistic. I mean, I loved your talk, Mirza, earlier. It was really comprehensive and very good. I want to say this, too. I mean, we've got a lot of medical students here, and I think when new technology arrives on the scene, you've got artificial intelligence, you've got robotic surgery, you've got, I mean, think back on the endoscope or the laparoscope in the mid and early 90s. These things change the way we do things, but it has to be evidence-based. And fundamentally, you cannot rely on an individual technology to actually get you to the end post. It's got to be applied diligently and rigorously. So you have to be adept at the technology, meaning that the training that you have to do to equip yourself to use it still comes with a learning curve, and that there is an error margin into an entity that you're going to be trusting to give you a more accurate result than yourself. So fundamentally, it brings a bit of a chasing your own tail type of thing, because you want to displace the trust of perhaps your failing hand or your quivering hand of your fatigue into something that also has a fallibility entity, and that you might need to actually, which one is actually more fallible than the other. So I want to just state one thing. When you do spinal surgery, you actually have one of three outcomes in mind. You have to either, or there are only three indications for spine surgery. One is for neurological fallout, the second is for instability, and the third is for deformity. And effectively, everything that we do in spine surgery revolves under those indications. So when you start looking at instability and you have to fuse something, you want to ask a robot to help you to put in pedicle screws. There are some that you can do very easily, that usually comes with your basic training, and that there are some that are very hard. So when you're going to take your utility, such as robotics, and apply it, it has to be applied on the case that you need to augment your skills with. And the real challenge then is you looking directly at yourself and identifying your limitations and where you're going to need something that has a lesser fallibility score than you do. So the trust has got to be into the entity to make the end product better. And when you're trying to achieve something as a spinal fusion, by placing the pedicle screws, there's no slap on the shoulder and to say, look, they're in, good job, the operation's done. That's just a scaffold to achieve what you want to achieve at the end of the day. So you have to always be diligent and keep your eyes on the end goal and say, look, I'm going to use a robot. I'm going to use AI intraoperatively to identify my tumor or to help me with my diagnosis, but I have to remember what I'm here to do, and whatever I'm using has got to decrease the risk to the patient. So I'm going to put that out there, Mirza. Let's hear your side.
Okay. Thank you, Ian. I can only agree on all the things you've said. You know, even in countries which can afford themselves to have several tens, or in case of China, for example, several hundreds of departments which have robots which cost between 100 and 300,000 euros, with a surgery cost, a single surgery cost of additional 500 euros. So even in these countries, you have a lot of very, very good spine surgeons who use only their experience and anatomical knowledge. And also the research has shown, if you compare experienced, and this clinical studies, experienced spine surgeon versus any kind of technology, experienced spine surgeon almost always wins, because even if he doesn't have perfect accuracy of the pedicle screws, even if they are not all GRSA screws, they are screws which don't need to be revised. Patient is doing well. As you said, he either has a neurological deficit which is resolved, or either he doesn't have instability, or he has some kind of positive clinical outcome. So the question is here to reduce the learning curve of a spinal surgeon becoming an experienced spine surgeon, if you know what I mean. So the thing is, if you start to use a robot at a very early stage of career, of course, you will be in a certain way decapitated of knowing the anatomy, like somebody who doesn't have it. But the idea behind this is that you are going to have less patients on your conscience, so to say, and that you will have less complications during your development. And I think it's not good for someone who is starting with spine surgery to concentrate only on innovations and only on technology, or to work only with robot. I think you have to know the classical fluoroscopy, pedicle screws, the navigation, and the robotics. Now in Germany or in the States or in the Western world is nowadays, if you don't use the navigation, if you have possibility to use it, that can also, and then something goes wrong, that can also have a certain lawsuit potential, because you didn't use the best technology which you have at your disposal. So I think that the more we use robots, the more the market is going to push the development towards smaller robots, handier robots, robots which then don't cost 100,000 euros, and which you can apply everywhere in the world. But since we live in a very unfair world, and you have a great disbalance between 15% of the world which is living fine and 85% which are not. I think the era of the normal or classical spine surgery is not over, and it's never be over. But I think robots are here, and they are here to stay.
Absolutely agree. I mean, I think your point about relying too much on technology and not being able to bail out. I mean, if you think about a pilot, if the autopilot is dependent on landing the plane and suddenly malfunctions or something goes wrong, you'd certainly want to be in a plane with a pilot that knows how to put it down. So it's exactly the same thing. I mean, I think the cautionary tale here is that it is about knowing your own limitations and applying, as Prof. Benzel says as well, applying AI and applying robotics to benefit your patient, which is augmenting your own skill. I mean, it's here to stay. It's going to get better. And perhaps if we have this conversation in 10 years from now, we're going to laugh at the robot you had on your slide. But and particularly the way that technology is multiplying and getting exponentially better in time. But fundamentally, we still rely on the human interpretation of all the inputs that you deal with during an operation. And we're asking a robot to deal with one specific navigated input and technical entity, which even in that sense can go wrong. I mean, I'm most definitely for robotic surgery to try and help and to try and make us better. But I do caution against people who like to use one hammer and smash everything with it to make the patient better.
Yeah, you're right. Internet is full of screws which are laying in abdomen, or 30 centimeters lateral to the, or 3-4 centimeters lateral to the pedicle, or going through the spinal canal, which were implanted by a robotic guided surgery. And it is prone to errors. It makes surgery a lot longer, especially when you start to use it. We have at our department a colleague, she's a PhD in medical informatics. She takes care of the robot and of our intraoperative CT. If you don't have that and you have an installation issue, you have a technical issue, then you are totally lost. So this technology works if you have you need to have a large amount of resources. The training for it is very expensive. Costs generally are expensive. So I think that is something which will need years and years and decades of development. It still did not develop how we hoped 30, 40 years ago. And I think for spine surgeons in the next 30, 40 years, that's what you said, anatomy knowledge, clinical knowledge, patients, traditional way of surgery is also never going to leave us.
Maybe just a comment on the AI. I mean, the speaker, Dr. Sayed, has mentioned the radiology AI. I mean, we know that is vastly starting to become a standard in its own right, basically based on the fact that it is a rapid diagnosis. The machine needs a second to look at an image and actually have a result of that image. And he showed the example of an intraparenchymal bleed, a subdural hemorrhage, and the machine can really save you 15, 20, 25 key minutes in neurotrauma, and even have peripheral diagnostics done. So in where I'm from, Africa, in South Africa, there'll be many centers that might have a CT scan, but no radiologists. So CT scan can happen, and then there's bulk radiology. So you can have a very quick and rapid response, or actually action initiated on a scan that's abnormal. At the same time, all of these diagnostic...
Apologies. If you're able to conclude.
Roughly. Perfect. Okay, everything that is happening in AI and robotics is augmenting our fundamental skills at the moment. We must be very careful not to rely on those as individual entities and replace the basic skills to help ourselves if for some reason those weren't available to us.
Thank you very much, Professor Flock and Dr. Poskic. We're heading towards the quiz. The link is shared in the chat box. Please tap on the link to fill the quiz. The participants of the quiz will be awarded a certificate of participation via email. I would also like to thank Professor Salman Sharif, Sidra, the coordinators, my co-host, Dr. Alicia as well, Dr. Saad, and Professor Sandeep as well, and all the faculty for organizing this lovely conference. Thank you.
Thank you.
Thank you, guys. Let's all have our cameras on so we get a group photograph. And I must tell you, we are sending this live to China as well, and in the Chinese translation. And Zen Chen, our friend from China, had arranged the translator and conveying to many people there. And smile, everyone. Imad, let us know when it's done.
Yes, thank you, everyone.
Okay, thank you, guys. Bye-bye.
Thank you, everybody. Have a nice
Wonderful having you here.